I'm Dr. Rahul Bapat, Chairman for CME Committee. Today is the first webinar by IMA Thane, and it's all efforts to arrange this is by our Honorable President, Dr. Santosh Kadam sir. So the first speaker of the today's meeting is Dr. Deepanjan Haldankar. Yeah, Dr. Deepanjan Haldankar is today's our first speaker, and this is our Haemoto Onco meet, and he's going to talk on the basic line of the new treatment of the multiple myeloma. Dr. Deepanjan Haldankar is MBBS from JIPMER and MD from PGI Chandigarh. He did his DM clinical hematology and he is a gold medalist. His fellowship in leukemia from BMT Canada, ex-visiting physician Fred H. Cancer Research, Washington, USA. He has 12 publications. Areas of his interest are blood cancer, bone marrow transplant. Consultant hematologist and BMT at Wocott Hospital Limited since August 15 to April 20. Now he is attached as a consultant hematologist and bone marrow transplant at Jupiter Hospital, Thane since May 20. So over to Dr. Deepanjan Haldankar.
Thank you, Dr. Rahul. Thank you, Dr. Santosh sir. I'd like to express my sincere thanks to IMA for giving this opportunity to be the speaker in their first webinar. And the first topic actually I'll be talking about is treatment of newly diagnosed multiple myeloma. So I've made it a case-based presentation, and I'll be discussing two cases basically. One is of transplant eligible myeloma patient and another of transplant ineligible myeloma patient. The focus of my talk is going to be on how to identify and how to have a low threshold for suspicion of multiple myeloma. My next speaker, Dr. Aniket, will be covering about the renal complications of multiple myeloma. So I won't be going into that part of the topic in details. So the first topic is about treatment of newly diagnosed multiple myeloma. This is a case-based discussion. My main focus will be on when to suspect multiple myeloma. And the treatment I'll be covering under the following headings: treatment of multiple myeloma patient who is a transplant eligible candidate, and treatment of multiple myeloma patient who is transplant ineligible, that is for whom we cannot do bone marrow transplant. So my main focus will be when to suspect multiple myeloma in a patient. So this is my first patient. She's a 60-year-old female patient, known case of diabetes and hypertension. She actually presented to us with history of chest pain and pain in bilateral knees, for which NSAIDs was prescribed, but still her pain was not going. So she presented to us just with anemia. Hemoglobin, as you can see, is 8.8. The WBC count is slightly reduced, 3040, and platelet count is normal, 1,94,000. So further elaborating on the anemia, her indices are normal. So MCV is 95. So it is a normocytic normochromic anemia in an elderly patient. And the differential count is maintained. There are no atypical cells. The platelet counts are also normal. So for workup, the basic workup we did, and her creatinine is also normal. The uric acid, calcium is normal. Electrolytes were also normal. For workup of anemia, how to approach anemia? So we did first the nutritional causes. So the iron profile was done, which was pretty okay. And similarly, vitamin B12 was normal. The viral markers were all negative. So what is next to be done? So whenever we get an elderly patient who comes with, say, bony pain and normocytic normochromic anemia, we have excluded the nutritional causes. So that is the point when we should keep suspecting that, yes, it could be multiple myeloma. So what is to be done next? So the next step that we usually do is a serum protein electrophoresis. And as you can see here, the serum protein electrophoresis is showing a peak here called as the M band. Okay, so the M band is quite significant. It is 6.55 gram%, and it is seen in gamma region. So for workup of myeloma, the first test that we did here is called as serum protein electrophoresis. Now what is to be done next? We see the kappa lambda ratio. So the kappa lambda ratio here is also significantly deranged. This patient was having a normal renal function, creat of 0.8, but the normal range for kappa lambda ratio is 0.26 to 1.65. In her case, the kappa lambda ratio was significantly deranged. It was as high as 373. And beta 2 microglobulin. So beta 2 microglobulin is also significantly raised, normal being up to 2,100. In her case, it was more than 7,500. So the suspicion for myeloma grows, and what is the next steps to be done for confirmation? We did a bone marrow test. The bone marrow test, as you can see here, is showing hypercellular bone marrow with 25% plasma cells. So the normal plasma cells are less than 5%. Anything more than 10% is diagnostic of multiple myeloma, and there is plasma cell dyscrasia consistent with myeloma. So next, what is to be done? So in addition to bone marrow test, to further prognosticate, we do the test called as FISH panel for multiple myeloma. So here we isolate the plasma cells and we check for multiple genetic rearrangements. I'll be elaborating this further. So some of these genetic rearrangements are good risk, some intermediate risk, and some poor risk. So this patient, fortunately, so all the genetic rearrangements were tested and she was negative. Her LDH lactate dehydrogenase was within normal limits. A PET CT scan was done for looking for lytic lesions, and there was no evidence of lytic lesions in any of her bones. So what next? So this is what I was talking about. There are certain genetic risk factors which are high risk. For example, deletion 17p, translocation 1416, 1420, and then high risk genetic signature on gene expression profiling. There are some which are intermediate risk. For example, translocation 414, cytogenetic deletion 30, hypodiploidy, and plasma cell level index more than 3%. And there are some which are standard risk. So why this is important? Because the prognosis varies. For example, in high risk patients of myeloma, based on the genetic risk factor, the median overall survival is just 3 years. On the other hand, intermediate risk is 4 to 5 years, and in standard risk, it is up to goes from 8 to 10 years. So this is about diagnostic evaluation for myeloma, which I have already kind of covered on the case-based approach. So first is obviously history and physical examination, a CBC, additional lab test. So serum protein electrophoresis, immunofixation, serum free light chain assay, again, calcium, look at the renal functions, burn create electrolytes, serum albumin and beta-2 microglobulin, LDH, and additional testing based on preliminary analysis. In addition, we do 24-hour urine electrophoresis, radiological, we assess to look for bony disease. We can do either by skeletal survey, which was mainly previously done based on X-rays, MRI vertebral compression fractures are suspected, and PET CT to look at lytic lesions. So then how do we proceed? So we establish the diagnosis of myeloma. So it can be MGUS, smoldering, or active myeloma. I'll be coming to this definition later. We determine the subtype. So subtype could be either heavy chain or light chain myeloma. It can be non-secretory myeloma. It can be solitary plasmacytoma. We determine the stage. So the stage is based on international staging system, which we use more commonly. Previously also, Dury-Salmon staging was used. We estimate prognosis. So this I have already shown. So the prognosis is based on cytogenetics, the various genetic markers that I showed. It is also based on serum albumin, beta-2 microglobulin, and DNA. And then we need to identify the need for immediate intervention. So what are the emergencies in a multiple myeloma patient can present with? A myeloma patient can present with various emergencies. For example, there can be severe hypercalcemia. The myeloma patient can present with acute renal failure, can be cord compression, where the patient can present with paraparesis, or there can be severe pain or impending fracture. So these are the emergencies that we need to identify when we're working up the patient, and such emergencies need to be dealt immediately. So now, how to classify whether this is MGUS, smoldering myeloma, or multiple myeloma? So this classification is, so in MGUS, basically, the M protein level is less than 3 gram per liter. The plasma cells in bone marrow are less than 10%, and there is no CRAB. What is CRAB? CRAB stands for hypercalcemia, renal dysfunction, anemia, and bone disease. So what about smoldering myeloma? In smoldering myeloma, the M protein value is more than 3. The bone marrow, the plasma cells are between 10 to 60%. And again, there is no CRAB or SLIM. So what is SLIM now? So SLIM is more than 60% plasma cells. And the ratio between involved and uninvolved ratio in free light chain is more than 100. That is the light chain. So kappa and lambda ratio is more than 100. So that makes it basically biomarker of disease, and more than one focal lesion detected by MRI studies. So in smoldering myeloma, so the plasma cell amount is between 10 to 60%. The M protein is can be more than 3, but there is no CRAB criteria is not met, and the SLIM criteria is also not met. Now, what about multiple myeloma? So in multiple myeloma, the plasma cells in bone marrow are more than 10%, or there is evidence of extramedullary plasmacytoma, and there is one or more myeloma defining events. So that is either CRAB criteria or SLIM criteria has to be met for classifying as multiple myeloma. So for example, this patient had presented with severe anemia, and the bone marrow, the plasma cells were 25%. So straight away, this patient is meeting criteria for multiple myeloma. So what about ISS staging system? I have already shown you the cytogenetic classification, what is good risk, what is intermediate risk, what is poor risk. Traditionally, what was used was ISS criteria, and on top of it, now the cytogenetic criteria has been incorporated, and now it is called as revised ISS staging. So what is the ISS criteria based on? Very simple. So beta-2 microglobulin less than 2.5 and albumin more than 3.5. So this makes it stage 1. What is stage 2? That is neither stage 1 or stage 3. So then what comes is, what is stage 3? Stage 3 is beta-2 microglobulin more than 5.5. Straight away it makes in stage 3. So our patient, the beta-2 microglobulin was 7.5. So straight away it is ISS stage 3. Now what is revised ISS or RISS criteria? So in RISS, in addition to this traditional ISS staging, we incorporate the genetic factors. So ISS stage 1, there is no high risk abnormalities, no LD, so normal LDS, that makes it ISS stage 1, RISS stage 1. What is RISS stage 3? So RISS stage 3 is ISS stage 3 and presence of either high risk abnormalities or elevated LDH. So that makes it RISS stage 3. And neither 1 or 3 makes it RISS stage 2. So this is about the genetic risk factors, which I have already covered. So there are certain high-risk genetic abnormalities. Then double-hit myeloma is presence of 2 high-risk genetic abnormalities. There is even triple-hit myeloma where we have more than, like we have 3 presence of 3 genetic abnormalities, high-risk genetic abnormalities. So we have seen about the diagnostic workup. We have seen about the staging. So what about the natural history of myeloma? So whether we can cure myeloma patients or what happens to them over a course of time? So this is what happens. So when we detect active myeloma, we start the patient on first-line therapy. The patient typically goes into remission. So the disease gets controlled, but the disease does not get eradicated in most of the patients. So the patient usually does not get cured. What we achieve is a functional control. So this patient, the disease remains in plateau phase for a significant period of time. And then eventually the patient does relapse. So what we do when the patient relapses, we start the patient on second-line therapy. So what after second line therapy, again the disease reaches to some control, but again the disease eventually relapses and then we start third line therapy. So typically as the patient keeps on relapsing, the duration of remission also comes down. So if the patient typically is in remission for about 2 to 3 years after first line therapy, after 1 year after the second line therapy, often we get a less duration of remission, that is maybe 1.5 to 2 years. So now coming to the treatment approach, you have diagnosed the myeloma patient. Now how to treat this? So this is basically evolving landscape of myeloma treatment over last 50-60 years. So initially melphalan and prednisolone was the most common used regimen. So now we have got all the newer IMiDs, that is carfilzomib, bortezomib. We have got the newer IMiDs, that is lenalidomide, pomalidomide. And in addition to this, we have got the bisphosphonates, so which form an essential part of myeloma treatment, especially for the bone disease. So this shows the new treatment sequence versus the old treatment sequence. So previously for patients, we used to give either VAD, that is vincristine, adriamycin, dexa. Bone marrow transplant came in 80s, 90s. And followed by bone marrow transplant, either we used to give nothing or we used to give some dose of prednisolone and thalidomide. And once the patient used to relapse, we had very few options. But now the treatment landscape have changed. So we have all these gamut of drugs. I will be covering this few in my subsequent slides. So for example, we have thalidomide, dexamethasone, we have lenalidomide, dexamethasone, we have triple regimens. So bortezomib, lenalidomide, dexa, bortezomib, thalidomide, dexa, cyclophosphamide, bortezomib, dexa. So all these are effective chemo regimens that we have now for newly diagnosed patient. And then for consolidation, typically we do bone marrow transplant and follow it with a few cycles of chemotherapy. Post consolidation, so we start the patient on maintenance. So maintenance can be either through bortezomib, can be through lenalidomide, or can be through thalidomide. What do we do when the patient relapse? So for relapsed patients, we have the newer drugs, for example, carfilzomib, pomalidomide. We have monoclonal antibodies against CD38. So CD38 is a marker which is expressed in on plasma cells. So we have newer monoclonal antibodies, for example, daratumumab. We also have elotuzumab, so again a monoclonal antibody which targets specifically the myeloma cells. We have histone deacetylase inhibitors, we have bendamustine. So we have got basically a variety of options to target even the relapsed disease. So now starting with the treatment scheme. So this, I said like, first we see, whenever we see a patient, we try to classify whether the patient is transplant eligible or the patient is transplant ineligible. So we do something called as the initial therapy. I will be describing this further. We follow this up with consolidation and maintenance for transplant eligible patients. For transplant ineligible patient, often this is kind of a continued therapy where we merge the consolidation maintenance therapy. And then eventually when the patient relapses, we do treatment for relapsed disease with all the options that I showed you in previous slide. So in addition to this, supportive care forms a very important part of myeloma treatments, specifically the treatment of bone disease, treatment of renal complications, DVT prophylaxis, treatment of infections. So all these form a very essential pillar to support the myeloma treatment. So as I showed you that whenever we see a patient of multiple myeloma, our first job is generally to determine that whether this patient is transplant eligible or not. So these are typically the criteria that we take in people take in United States to consider a patient who is not eligible for autologous transplant in myeloma. So the age cutoff, so strictly actually there is no age cutoff, but functional age more than 77 years, If there is liver dysfunction with bilirubin more than 2, the ECOG performance status 3 or 4, unless it is due to bone pain, and there is presence of significant dyspnea in IHA class 3 or class 4. So these patients are generally not transplant eligible. In India also, most of the people are comfortable doing transplant up to between 65 to 70 years of age. So now starting with approach to transplant eligible myeloma. So what do we do with transplant eligible myeloma? So those patients who are functionally preserved, who have got a decent renal function, who have got a decent liver function. So for standard risk patient, we do induction chemotherapy with VRD. What is VRD? VRD is lenalidomide, bortezomib, dexamethasone. This we give for 3 to 4 cycles. And then we have two options. We can go in for early autologous bone marrow transplant, follow it up with lenalidomide maintenance, or after these 3 to 4 cycles of chemo, we can cryopreserve the stem cells and continue lenalidomide, bortezomib, dexa for 5 to 8 more cycles, followed by lenalidomide maintenance. So this is the scheme of treatment for standard risk myeloma. So how do we classify standard risk and high risk? This I had already shown you. This is based on the cytogenetics as well as the albumin and beta-2 microglobulin. So what about high-risk multiple myeloma? So these patients, we give the initial treatment. So we give bortezomib, lenalidomide, dexa. Nowadays, often we are using quadruplets. What is quadruplet? We are using 4 drugs for treatment of newly diagnosed myeloma to bring in the deeper response in these patients. So we use daratumumab, bortezomib, lenalidomide, dexa. We give it for 3 to 4 cycles, and we target early bone marrow transplant, followed by bortezomib-based maintenance for high-risk patients. So what about transplant ineligible patients? So this again I'll be covering when I discuss the next case. So in transplant ineligible patients, for standard risk patients, we continue bortezomib, lenalidomide, dexa for 8 to 12 cycles, follow it up with lenalidomide maintenance, or we can also give daratumumab, lendexa until progression. For high risk patient, again bortezomib, lenalidomide, dexa for 8 to 12 cycles, but here the maintenance is usually bortezomib based, whereas in standard risk patient it is generally lenalidomide based. So I won't go into details of the randomized control trials and studies showing what is the rationale for this treatment scheme, but just I'll be showing 2-3 slides. So what is the rationale for selecting bortezomib-based treatment? So in this is basically meta-analysis of phase 3 randomized control trials, so level 1A evidence. So median time to treatment progression for bortezomib-based therapy versus non-bortezomib-based therapy. It was 37.5 months versus 31.3 months. So p-value being quite significant. So generally for newly diagnosed myeloma, bortezomib-based therapy is a standard of care nowadays. So what is the rationale for putting the patients on lenalidomide after bone marrow transplant? So again, I won't not go into these figures, but this is basically again meta-analysis of phase 3 randomized trials of lenalidomide maintenance therapy following bone marrow transplant. And as you can see here, the blue line shows the lenalidomide maintenance graphs and the yellow line shows placebo versus maintenance. So in terms of progression-free survival, the risk of progression or death was reduced significantly by 52% with lenalidomide maintenance versus placebo or observation. Hazard ratio is very much skewed in favor of lenalidomide maintenance. So what about overall survival? Again, the blue line here shows lenalidomide-based maintenance and the yellow line placebo or observation. So following bone marrow transplant. So we see that with lenalidomide maintenance, there is even 25% reduction in the risk of death with lenalidomide maintenance versus placebo or observation. So what about bortezomib-based maintenance? So again, meta-analysis of phase 3 trial showing significant PFS benefit for bortezomib even in high-risk myeloma having deletion 17p. So where do we get in the data for bone marrow transplant? So these are again few of the studies. I'm not going into details, but as you can see that IFM 90 study where conventional chemo was compared with bone marrow transplant, significant overall survival difference at 7 years. So 25% versus 43% overall survival difference at 7 years. There are some studies which have not shown a significant overall survival difference, but all of them uniformly show that there is significant difference in the event-free survival or progression-free survival. So definitely bone marrow transplant increases the duration of remission. According to some studies, it also increases overall survival, but these have not been replicated in few of the studies. So now coming back to our case. So our patient, she is a 60-year-old female. She is ECOG 1 performance status. Her comorbidities include diabetes, hypertension, and ischemic heart disease. She is standard risk by her cytogenetics. So definitely she is transplant eligible. So how did we treat her? We started her with weekly lenalidomide, bortezomib, dexamethasone. Along with that, we gave her monthly zoledronic acid for skeletal disease. So for infection prophylaxis, we put her on acyclovir, and we also give pneumococcal vaccine to such patients routinely. After 4 cycles of chemotherapy, her M band significantly reduced from 6.5 to 0.4. So at this point of time, we gave her both the options. One option was to collect stem cells after 4 cycles, follow it with transplant, versus continue lenalidomide, bortezomib, dexamethasone for 12 months. So she opted actually for bone marrow transplant. So we treated with 4 cycles of chemotherapy, lenalidomide, bortezomib, dexa. She achieved VGPR as I shown you in the previous slide after 4 cycles, and then she underwent autologous bone marrow transplant. So following this, she was started on lenalidomide maintenance, with which she got recurrent urinary tract infections. So we changed her to bortezomib maintenance. So I'll just cover the transplant course briefly. So her comorbidities included, she was a 62 female, diabetic, type 2. She had open angle glaucoma, she used to get recurrent UTI, known cause of ischemic heart disease. She had moderately restrictive pulmonary function, and she was obese with BMI of 35. So this is not her. So this is just a dummy patient. But how we do the bone marrow transplant? So we give the patient growth factors for 4 to 5 days. So the growth factors basically bring the stem cells from bone marrow to the peripheral blood. Then we hook up to the machine hook up the patient to an apheresis machine, where we collect the stem cells by peripheral blood harvest. We can store the peripheral blood collected stem cells if you're planning an immediate transplant at 4 degree, or if you're planning a delayed transplant, it can be stored at minus 80 degree in a cryopreservation unit. So for immediate transplant, we generally give the patient high-dose chemotherapy, which is melphalan, and after 24 hours, we infuse back the stem cells to the patient. So the stem cells then go and home to the bone marrow niche, wherein it starts producing the new bone marrow cells. So what happens is basically the high-dose chemotherapy that we give, it brings down the absolute neutrophil count from 2,500 to very low absolute neutrophil count, so less than 0.5. And during this period, the patient is susceptible to high risk of infections. So this is a period of peak neutropenia, which predisposes the patient to infection-related complications. And this is a very tight rope work for the transplant team now. So coming to the transplant course of this patient, so this patient we mobilized with GCSF, that is growth factor and plerixafor, which is a stem cell mobilizing agent. After this, we check the amount of CD34 cells in the peripheral blood. So anything more than 20 is quite good. So in this case, the CD34 cells was 21.39 cells per microliter. So after that, we connect the patient to a stem cell apheresis machine, where we collect in the stem cells, and we check the adequacy of collection. So adequacy of collection, anything more than 2 to 2.5 is quite good. So in this case, it was 4.9. So quite good number of stem cells. Once we collect, we give the patient high-dose chemotherapy with melphalan, and after 24 hours, we infuse back the stem cells. So this is what I was talking about. So because of the high-dose chemotherapy, the WBC count comes down and the platelet counts come down severely. So in case this patient, the total WBC count dropped to 80. So it drops even, sometimes it can become even 0, and the platelet count also drops generally to less than 10,000. So during this period, the patient has mucositis because of the high dose chemotherapy. She developed febrile neutropenia, she developed neutropenic enterocolitis, grade 2 oral mucositis. She did a few hypoglycemic episodes, and often the patient we keep in isolation for about 2 to 3 weeks, so they can land up to depression and delirium. So gradually this patient's engrafted, wherein with the WBC count normalized, the platelet count gradually increased, and she is on maintenance chemo so far, with M band being negative. So this I've already shown. This is the reason why we do bone marrow transplant, because although it is a high-risk procedure, but overall it increases the event-free survival as well as the overall survival. So I move on to my next case, which is basically a myeloma case in transplant ineligible patient. So this patient, the presentation is quite simple, quite interesting. So this patient presented with facial nerve palsy. So this is an elderly patient, 74-year-old patient, presented with history of chest pain and back pain for 2 months and deviation of angle of mouth for 2 days. There is no history of trauma, no history of fever, glandular swelling, blood transfusion, or weight loss. On examination, the patient had mild pallor. There was right-sided element type of facial palsy. There was no organomegaly or no lymphadenopathy. So starting with the basic investigation, this is the CBC of the patient. The hemoglobin slightly reduced, 9.1. WBC count bit reduced, 2,530, but differential count quite maintained. Platelet counts normal, creatinine normal. The chest X-ray done showed multiple lytic lesions and rib fractures. So possibilities, multiple myeloma or metastasis with unknown primary. So how to work up this patient now? So this is the CBC of this patient, starting with the CBC. Again, as I showed that the neutrophil count, the differential and platelet count is quite maintained, but just normocytic normochromic anemia. ESR quite high, 140. So the liver function test, you can see that the total protein is quite raised, 13.5, and the AG ratio completely reversed. So the globulin quite high, that is the globulin being 11.06 and albumin 2.44. So the AG ratio completely reversed. So for further workup, a bone marrow test was done, which showed plasma cells increased 15 to 20%, and these were confirmed on immunohistochemistry as well, showing lambda predominance. The serum protein electrophoresis showed a huge M band of 8.76 gram%, and this was further qualified to be monoclonal gammopathy in IgG lambda region. So we see that the quantitative immunoglobulin also IgG is quite raised. The kappa lambda ratio you see in this case is normal. So this brings us to an interesting point that even with a patient who is having overt myeloma, the kappa lambda ratio can be normal. So therefore, we should always proceed sequentially. That is, we should first get the serum protein electrophoresis, immunofixation electrophoresis, and then proceed on to serum free light chain ratio. If we do serum free light chain ratio, we might miss this kind of cases of multiple myeloma. What about the cytogenetics and FISH study? So there was no evidence of deletion 11q. Deletion 13q was present. There is no 17p deletion and no any IGH translocation. So now coming into the radiological findings, again quite interesting. So here we can see the multiple rib fractures in this patient and the CT scan chest as well as multiple vertebral fractures. This patient had presented with a facial nerve palsy. So we did a MRI of the brain as well, so which showed presence of lytic bone lesions in the petrous parts of the temporal bone. So in addition, the skull, it showed multiple lytic lesions here. As you can see, the well-defined punch-out lytic lesions seen here on the skull MRI. And in addition, the patient did have wedge compression fractures at multiple spinal levels. So as seen here, and again, closely you can see here, the patient is having wedge compression fractures of T5 vertebra over here. So summarizing the radiological findings, this patient HRCT chest showed multiple well-defined punched-out lytic lesions. MRI brain showed numerous skull-based lytic lesions, and this was also involving the right jugular fossa, probably accounting for the facial nerve palsy in this patient. Screening MRI spine showed wedge compression fracture of D5 as well as degenerative disc disease of cervical spine. So classifying this patient, whether MGUS, smoldering myeloma, or multiple myeloma, no problem. So the bone marrow, the plasma cells are more than 10%. Patient is having anemia as well as multiple evidence of lytic lesions. So straight away, this is a patient of multiple myeloma, IgG lambda ISS3 and deletion 13q14. So now coming to approach to treatment of this patient. So what about multiple myeloma with facial nerve palsy? What about treatment approach to this patient, and what to do about the asymptomatic spinal fractures of this patient? So facial nerve palsy in multiple myeloma has been reported due to involvement of temporal bone, as was in this patient, but this is quite rare. Another case report of facial nerve palsy in multiple myeloma, and this was shown to be because of lytic lesion in left temporal bone, as was in our patient. So rarely multiple myeloma can have involvement of the CNS by plasma cells directly infiltrating into the meninges, and such kind of plasma cells here seen on the CSF. So that was not there in our patient. So treatment approach to this patient, this part I've already covered. So this patient is having cytogenetic deletion 13, so basically falls under the intermediate risk cytogenetic risk factor. So this patient is 74 years of age, so it is transplant ineligible patient. So what to do about such patient? Generally, we give lenalidomide, bortezomib, dexa 8 to 12 cycles followed by lenalidomide maintenance, or we can give daratumumab, lenalidomide, dexa. Daratumumab is quite costly. This patient could not afford. So we gave lenalidomide, bortezomib, dexa first 8 to 12 cycles and followed it up with lenalidomide maintenance. So the anti-myeloma therapy I've already covered. What about the bisphosphonates? So bisphosphonates we give routinely to all myeloma patients, basically for the bone disease. Now coming to the role of radiotherapy and surgery. So when to refer the patients for radiotherapy? Radiotherapy of spine is usually employed in patients with uncontrolled pain, or if there are impending vertebral fractures with spinal cord compression. What about surgery? So the role of surgical intervention is limited to presence of unstable fractures, presence of spinal cord compression, especially if it is caused by radio-resistance mark or bony fragments protruding from a vertebral fracture. So these are the situations where we refer our patients to a spine surgeon. Now, what about this patient? So this patient received 9 cycles of lenalidomide, bortezomib, dexa, followed by lenalidomide maintenance. He was also treated with monthly zoledronic acid, and he received vaccination with pneumococcus and influenza. What about complications? So this patient developed steroid-induced diabetes, for which he required treatment with all these hypoglycemic agents. He did develop right lower limb pneumonia after first cycle of chemotherapy, for which the patient required IV antibiotics and responded well to treatment. So coming to my last few slides, so just I'll be summing up the treatment of transplant eligible myeloma patients. So transplant eligible myeloma patients, we basically try to classify them in the standard risk or high risk. We typically give them treatment with lenalidomide, bortezomib, dexa, followed by early autologous stem cell transplant, uh, followed by lenalidomide maintenance, or we can preserve the stem cells for future, cryopreserve them, and follow it with few more cycles of chemotherapy, lenalidomide, bortezomib, dexa, followed by lenalidomide maintenance. For high-risk myeloma patients, we can give either lenalidomide, bortezomib, dexa, or we can use daratumumab also, followed by early transplant and bortezomib maintenance for the high-risk transplant-eligible myeloma patients. What about the transplant ineligible ones? So again, for standard risk patients, we give a combination chemo regimen, lenalidomide, bortezomib, dexa for 8 to 12 cycles, and we put them on lenalidomide maintenance. Or we can continue daratumumab, len-dexa until progression if the patient is able to afford daratumumab. For high-risk patients, we give this combination chemotherapy, lenalidomide, bortezomib, dexa, and follow it up with generally bortezomib-based maintenance. So this is my last slide. So summarizing the treatment of myeloma. So for most of the patients, we give triplet induction, where we use a combination chemo regimen. Bone marrow transplant for eligible patients. For frail patients, frail and elderly patients, we do consider therapy modifications where we use the chemotherapy drugs at lower doses. Maintenance therapy is to be optimized and individualized based on what side effects the patient is having during induction and what is the risk category of the patient. We need to give these patients aggressive treatment and careful monitoring. For high-risk patients, consider PI, that is bortezomib-based maintenance. And bone disease support treatment with antivirals and thromboembolism prophylaxis are critical for these patients. So with this, I'll be happy to take up any questions.
Very nice presentation of the newly diagnosed multiple myeloma by Dipanjan sir. So Dr. Over to Dr. Santosh Kadam sir for our felicitation of today's our guest.
Yes,
now
sir.
we'll take the second lecture of Dr. Aniket Hase. As Santosh Kadam sir has some technical problem, he will join, and that after 12:30 of this lecture we'll take our felicitation.
Yeah, after having learned about the basics of multiple myeloma and little bit about the complex treatment, now we go ahead with the renal part of it. To present that, we have Dr. Aniket Hase, who is a consultant nephrologist and kidney transplant at Jupiter Hospital, Thane. He has got good 6 years of clinical experience in nephrology. He is actively involved in full-time clinical nephrology, dialysis, and renal transplants. He has accomplished his DNB nephrology from Medanta, Medicity, and DNB in medicine. Quite often we come across situations when a patient comes to us with high creatinine and marginally low hemoglobin. That time we always have that doubt of multiple myeloma. Here Dr. Hase will throw light on this situation and will guide us how to go ahead with it. Yes, welcome Dr. Aniket Hase.
Thank you, sir, for the kind introduction. And at the outset, I would like to thank IMA Thane organizers, Dr. Santosh and Dr. Dipanjan, for giving me this opportunity to interact on this platform. So I would like to start with my presentation. So there has been a change in terminologies by the kidney disease, improving global outcomes. Recent controversies conferences changed the nomenclature of renal to the kidney to make it more simple for the understanding of general population. So initially we used to say acute renal failure, which has been now termed as acute kidney injury. Similarly, RRT, which is renal replacement therapy will now be called as kidney replacement therapy. Similarly, CRRT will be called as CKRT, and ESRD is called as ESKD, end stage kidney disease. But even now they say the end stage kidney disease has not to be said because it is very scary for the patient, and there is no end of life with the end stage kidney disease. Patient can still survive with dialysis and transplant. Therefore, the new terminology is chronic kidney disease requiring dialysis. So I will be discussing on plasma cell disorder, how they affect the kidney, how to suspect, how to detect, and how to manage. Dr. Dipanjan has covered the therapy quite in details. So multiple myeloma, basically disorder of plasma cells. So there is a neoplastic proliferation of a single clone of plasma cell producing abnormal monoclonal immunoglobulins and light chains that are fragments of it. These monoclonal light chains are not only produced by plasma cell, but they are also produced by other cells like B cells and lymphoplasmacytic cells. And these are produced in excess and they are non-functional and toxic to the tissues and hence cause tissue injury. So basically, what is a plasma cell? Plasma cell is a cell which originates from blood stem cell in the bone marrow. It leaves bone marrow as a B cell and differentiates into plasma cell in the lymph nodes. And the primary product of this plasma cell is antibody or immunoglobulin, which is a mediator of humoral immunity. Now, this is the immunoglobulin structure. So, and this is the antibody immunoglobulin structure. It's a large Y-shaped structure, as we can see. There are heavy chains, light chains. These are antigen binding sites. These are the effector sites, constant region from which the functions are mediated. And they are classified according to the heavy chain as IgM, IgG, IgA, or IgD, depending on the heavy chains. Now, what is monoclonal antibodies and what is polyclonal antibodies? So, as we have seen, a single clone of cell producing an antibody is called monoclonal. It detects only a single epitope, while non-identical beta cells, B cells, which produce different immunoglobulins, which detect multiple epitopes, are polyclonal antibodies. And these polyclonal antibodies we can see in sepsis, chronic liver disease, autoimmune disease, collagen vascular disease. So, what is the spectrum of kidney involvement in paraproteinemias? So, basically, the excess burden of heavy and light chains can affect the kidneys. Now, this is the functional unit of the kidney, which is the nephron, and the nephron consists of glomerulus and the tubules, and the interstitium and the vascular compartment. Now, these heavy chains and light chains can affect each and every component of this nephron. For this, the glomerulus is composed of capillaries, is a tuft of capillaries. There is an intervening tissue called as mesangium. There are endothelial cells, there are epithelial cells. So these paraproteins can involve each and every component, causing glomerulopathy, giving rise to deposition diseases like amyloidosis, also giving rise to proliferative features like proliferation of epithelial cells, subendothelial cells, and proliferative picture like MPGN like pattern. The next comes the proximal tubules. So normally the light chains are filtered freely from the glomerulus into tubules, and these chains are normally absorbed by these proximal tubules and they are metabolized. But when in excess, they lead to tubular injuries leading to proximal tubular dysfunction, Fanconi-like syndrome. And whenever the capacity of proximal tubule is overwhelmed, they are then further deposited into the distal tubules, wherein they go and get embedded on the TAM horsefall protein or the uromodulin, and leading to cast nephropathy or myeloma kidney, what we call, which is the most common cause of acute kidney injury in myeloma. The other parts which are involved are the interstitium, wherein these tubular injuries can overspill into interstitium, lead to inflammation and fibrosis. Similarly, these deposits can form in the vascular compartment. So the kidney disease is the most common complication of multiple myeloma. Approximately 50% of the patients of multiple myeloma experience acute kidney injury or chronic kidney disease sometime during the course of the illness. 20 to 50% of the patient may have presenting feature of kidney disease in myeloma, and kidney failure requiring dialysis, severe kidney failure requiring dialysis is seen in approximately 1 to 3% and even reported up to 12% in series. So let us begin with the cases. So first case, she was a 61-year-old retired government service employee, and as a retired citizen, she was aspirant of the world tour and embarked on the journey to Sri Lanka, her first tour. And there during the journey, she had a fall and had a pain in the left knee, and she took non-steroidal anti-inflammatory painkillers. And after 5 days, she managed and she was home. Then she presented with nausea, vomiting, decreased appetite. She had a decreased urine output. She was non-diabetic and non-hypertensive. Her on evaluation, her BP was 160/90. She was pale. She had a mild edema, and chest had bilateral crepes. Other systemic, there were no significant findings. Her blood workup showed anemia, which was normocytic, normochromic, mild leukopenia. Platelets were 150,000. Dipstick urine was negative for albumin, and there was no active sediment. Her creatinine was 10.5, sodium was 128, mild hyponatremia, uric acid 9, calcium 9. There was metabolic acidosis. USG showed normal sized kidneys and a suspicious soft tissue mass on the SWAS, for which MRI was done, which also showed that was suspicious for either a hematoma or a mass. So this was an acute kidney injury due to acute tubulointerstitial involvement, which was multifactorial because of the dehydration and NSAIDs requiring hemodialysis. So for further evaluation of the mass, a PET CT was done, which showed that the left psoas mass was metabolically active, and there were also some activity in the vertebral regions. So aspiration biopsy of the left psoas mass was done, which showed was positive for plasma cells. Meanwhile, serum electrophoresis did not show a M band, neither BJ proteins reveal any positivity. Meanwhile, the serum free light chain assay showed a lambda change were significantly elevated in 3000 milligram per deciliter, and subsequently bone marrow showed 40% of plasma cells, and immunofixation showed it was a IgG predominant. So this was an IgG lambda myeloma, acute kidney injury presenting myeloma presenting as acute kidney injury, which was IgG lambda. She was treated with bortezomib, cyclophosphamide, and dexamethasone. At 2 weeks, she became dialysis independent. At 4 weeks, her creat came down to baseline 0.8. At 8 weeks, her light chains were normal. And at 6 months, the follow-up PET CT showed resolution of the plasmacytoma. So it was an acute kidney injury due to acute interstitial kidney involvement and tubular involvement due to light chain cast nephropathy, which was precipitated by dehydration and non-steroidal anti-inflammatory drugs. So as we had seen, normally the light chains are filtered freely from the glomerulus, and they are absorbed by the proximal tubule and catabolized. However, when there is excess of free light chains, they may cause toxicity to mesangium and tubules. So in tubules, they are absorbed, they are processed by the lysozyme, and subsequently there may be inflammatory reactions leading to interstitial inflammation and fibrosis. And the excess of the light chains, which are beyond the absorptive capacity of proximal tubule, go into distal tubule, wherein they get embedded into time horse fall protein uromodulin and lead to cast nephropathy, giving rise to acute kidney injury. So this cast nephropathy is the most common form of acute kidney injury in myeloma. Other causes of acute kidney injury in myeloma will include acute tubular necrosis due to sepsis, hypotension, nephrotoxic drug like NSAIDs, dehydration, use of radiocontrast agents, and also post-treatment urate nephropathy or hypercalcemia. So learning point from this case where that cast myeloma nephropathy is the most common cause of kidney disease, acute kidney injury, and usually it occurs when the light chain burden is more than 100 milligram per deciliter. Proteinuria primary light chain is a presenting feature, and only 10% may have nephrotic presentation. These are light chain proteins. We have to remember that the urine dipstick may be negative, and sulfosalicic acid tests are positive to this. So on urine routine dipstick, this protein may not be detected. So we should have a high index of suspicion when for this acute kidney injury or chronic kidney disease in elderly, which is unexplained, and suspect myeloma. So we move on to the second case. So this was a 71-year-old gentleman. He had history of edema feet, puffiness of face, dyspnea on exertion, and palpitation. For palpitation, he had visited cardiologist. ECG, on ECG there was atrial fibrillation. He was evaluated and he was found to have a cardiomyopathy, and he was referred for further evaluation of nephrotic syndrome. History he complained of backache, weight loss, decreased appetite. There is no history of tuberculosis, fever, chronic drug interest, arthralgia, or arthritis. He had anemia. His BP was 110. Urine had 2+ protein, no RBCs. 24-hour urine protein was 6 grams. So creatine was 2.5, albumin was 2.5. There was hypertriglyceridemia, cholesterol was elevated, and so this was a nephrotic syndrome, and total protein was elevated with a protein gap. Hence, this prompted, and because for the nephrotic syndrome, kidney biopsy was done, and which was suggestive of amyloidosis. There was Congo red positive material on the light microscopy. Unfortunately, immunofluorescence was not available, and the patient was referred to us for the evaluation of amyloidosis. So whether it is a primary, secondary. So serum amyloid protein was negative. Protein electrophoresis again did not reveal any M band. Urine BJ protein were negative. PET CT was done to see the any metabolic focus and metabolic activity was seen in this vertebrae, and the vertebrate aspiration was done, and this showed plasma cells. And the free light chain assay showed kappa, which was very high, and immunofixation was IgG predominant. So this was a nephrotic syndrome, myeloma presenting as nephrotic syndrome, IgG kappa paraprotein deposits. So as we have seen previously, again, the excess light chain which are there in the circulation, they can exude into the mesangium and be toxic to the mesangial cells. They are processed by lysosome and they elicit inflammatory infiltrates, giving rise to inflammation and subsequently fibrosis, and they get deposited at fibrils or as granular deposit, giving rise to either an amyloid deposit or a light chain deposition disease. So this amyloidosis, because of light chains, these are free light chains which are get misfolded and they form into fibrillary pattern. These they get aggregated, and this amyloid is nothing but abnormal proteins deposited in the extracellular tissues and giving rise to various clinical manifestation depending on the tissues they get deposited. So last two cases we have seen, there was a cast nephropathy and there was primary amyloidosis. So one was IgG lambda and IgG kappa. But have you noticed that in both the cases, the protein electrophoresis had shown no M band and urine BJ protein was negative. So whenever we suspect a myeloma, we order these two tests, and if they are negative, we may not think further. So that is why which investigation to choose, which is more sensitive, which is more specific, whether free light chains or urine protein electrophoresis, serum protein, or immunofixation. So this is a typical serum protein electrophoresis pattern wherein the albumin and the globulins monoclonal spike is detected in the gamma region, and polyclonal may show a wide gamma region which may be seen in sepsis, chronic liver disease, autoimmune diseases, and collagen vascular diseases. Now, what SPEP can detect is only a spike, and it determines its amount. It cannot confirm the monoclonality. It cannot give idea about heavy or light chain, and it may not detect a small spike. Small M spike can be missed on serum protein electrophoresis. And what immunofixation can detect is it can confirm the monoclonality. It can determine whether it is a heavy chain or light chain specific, and it can even detect the smaller M spike. So if we see the reports, how they are reported, so the serum protein electrophoresis says it is a spike and quantifies it. It doesn't mention about monoclonality or immunoglobulin type, while immunofixation gives idea about what kind of heavy or light chain and interprets the monoclonality. So by doing only serum protein electrophoresis, we may miss around 13 to 20% of the cases of myeloma. The ideal will be serum protein electrophoresis with immunofixation, which may give us 100% sensitivity. At our center, we practice sending a serum protein electrophoresis with free light chain assay, which gives us a 90 to 100% sensitivity with cost effectiveness. So moving on to the next case. This was a 64-year-old female, diabetic, hypertensive, no history of IHD or CVA. She had a retinopathy, a diabetic non-proliferative retinopathy, and she was referred for high creatinine, which later settled down to 0.8, and as a for the workup of diabetic kidney disease. On history, she had a backache, weakness, pain in lower limbs. Urine protein was negative. RBCs were not seen. Protein was, however, 1.8 gram per day, 24 hours. There was anemia, ESR was high. There was a mild hyponatremia, and there was a protein gap. So this prompted us to look for a non-diabetic, whether she has a non-diabetic kidney disease. Hence, we did a serum protein electrophoresis, which showed M band, light chains, lambda light chains were on higher side, and immunofixation showed IgG subtype. So it was IgG lambda myeloma, and bone marrow done showed 30% plasma cells. So she was treated with bortezomib and steroid. She has a normal kidney function to begin with, and however, at the second week of the treatment, her creatinine increased to 3. And on further evaluation, her calcium was 6.8, phosphorus was 4.7, 7.5, uric acid was 10. She had hyperkalemia, and she was well hydrated, and there was no evidence of any nephrotoxic drugs in her drug list. So this was an acute kidney injury secondary to acute tubulointerstitial involvement on treatment initiation. So what are the causes? We have seen the causes of AKI in myeloma. It can be volume depletion, sepsis, hypercalcemia, tumor lysis syndrome, nephrotoxic drugs, infections, and sometimes there can be plasma cell infiltration itself in the kidney, which can give rise to interstitial inflammation and fibrosis. So in her case, after initiation of therapy, there was worsening of renal function. So it is most likely because of the chemotherapy-induced cell breakdown, which leads to hyperuricemia, hypophosphatemia, hypocalcemia, and hyperkalemia. So which leads to renal dysfunction. So it is important to explain the patient about possible worsening after the starting of treatment, and we need to prepare the patient well with alkalization, hydration, and urate lowering therapy, and monitor closely once the therapy is started. So acute kidney injury can occur after the initiation of myeloma therapy because of the tumor lysis. So moving on to the next case, along with the glomerular disease and CKD, we also have calls for electrolyte imbalances. So this was like on any other day call for a hyponatremia. So a 48-year-old female admitted under physician referred for hyponatremia. Serum sodium was 120. She was non-diabetic, non-hypertensive. She had easy fatigability. There was no loose motion. She was not on diuretics. She had a history of blood transfusion for anemia 3 months back. She was conscious. Euvolumic sodium was 123. Urine routine was done, which had shown proteinuria significant 3 plus. Bicarbonate was 18. There was metabolic acidosis. Uric acid was low. Phosphorus was low. So as a workup of hyponatremia, the first step we do is to see the serum osmolarity. So serum osmolarity, serum sodium is responsible for maintaining the osmolarity of the serum. So usually serum osmolarity is twice the serum sodium. So in this case, the serum osmolarity is 290, which the expected was around 240 to 250. So we say this is a pseudo hyponatremia. So to rule out pseudo hyponatremia, the other causes like cholesterol was normal, sugars were low, normal. However, there was a protein gap. So hyponatremia, it's pseudo hyponatremia with probably acidosis, low uric acid, low phosphorus, glucose in the urine, looks like a proximal tubular dysfunction, along with pseudo hyponatremia and a protein gap prompted us to evaluate for myeloma. So SPEP had shown M band of 3.4 grams and bone marrow had 30% plasma cells. So uh, the learning lesson from this is we have to read it in between the investigation to find the clues. There was pseudo hyponatremia, there was proximal tubular renal dysfunction, and the anion gap was low. So this was a myeloma presenting as pseudo hyponatremia with proximal tubular dysfunction. So monoclonal gammopathy, that is. So moving on to next case. This was a 60-year-old male, known hypertension on ACE inhibitors. He had edema, puffiness of face, decreased urine output, arthralgia, myalgia, low-grade fever. On inquiry, there was no history of diabetes, tuberculosis, jaundice, or any other systemic features. His urine protein was 2 plus, 24 hour was 6 gram, which was in nephrotic. So it was a nephritic presentation. He had anemia, normocytic, normochromic. Creatinine was 2.5, uric acid was 7.5, sodium, mild hyponatremia, mild acidosis, proteins of 5.6. So as a part of nephritic syndrome, serologies were done, which showed which were negative for ANA, ANCA, and there was a hypocomplementemia. So nephritic presentation, the first thing to come to mind is post-infectious glomerular disease, SLE, and pattern of injury, and cryoglobulin. So considering the C4 low as of the normal size, hence we had gone for a biopsy, and the biopsy said the biopsy was suggestive of eosinophilic amorphous deposits of cryoglobulin in the tubules. However, the immunofluorescence showed a lambda restriction. So again, which prompted us to look for monoclonality or the paraprotein, which may be the cause of the cryoglobin. So the serum protein electrophoresis was done, which showed M band, which was less than 3 grams. Immunofixation showed kappa lambda ratio, which was not significantly elevated for the creatinine. Cryoglobulins were positive. Bone marrow was normocellular, and plasma cells were 8%. And PET CT has no metabolically active bony lesion. So this brings us to the spectrum of myeloma, which Dr. Dipanjan had already discussed. The active myeloma, smoldering, and M-GUS. So this was fitting into M-GUS with M protein less than 3 gram, bone marrow showing less than 10% plasma. However, there was a kidney involvement. So this is termed as a MGRS. So this is a M-GUS with kidney involvement will be termed as MGRS. So there is a monoclonal underlying B cell or plasma cell monoclonal protein, which is not causing tumor complication, but causing kidney lesions. So MGUS with kidney lesion will be MGRS. So like myeloma we discussed can affect all the parts of the nephron on the kidney. Similarly, MGRS may be associated with deposit which may be organized or non-organized in form of fibril, microtubules, crystal, giving rise to amyloidosis, fibrillary GN. If the tubules are formed immunotactide or cryoglobulinic, or crystal inclusions in the proximal tubules giving rise to proximal tubulopathy, Fanconi syndrome, and crystal storing histiocytosis, while the non-organized deposit can give rise to light chain and heavy chain deposition disease, or what we had seen like the glomerulus giving rise to proliferative pattern. So end-stage kidney disease in myeloma. So patients with myeloma can progress to end-stage kidney disease and can be treated with hemodialysis or peritoneal dialysis. Those with end-stage kidney disease who survive for first 2 months have survival of up to 45% at 1 year and 20 to 30% at 3 years. And even though patient is dialysis dependent, it has been seen that those who respond to chemotherapy had a far better survival than those who didn't. So even if the patient is end-stage kidney disease and on dialysis, he has to be treated with chemotherapy for a better long-term survival. So dialysis, that's kidney replacement therapy in kidney failure. The conventional dialysis should be initiated for the usual indication and not for the removal of light chains. We will be seeing the free chain light chain removal in corresponding slides. AKI who require dialysis, hemodialysis is the preferred modality. Peritoneal dialysis is also an option, and dialysis indication will be standard like fluid overload, hyperkalemia, refractory acidosis, uremic symptoms. Now commenting on extracorporeal methods for light chain removal. So nephrotoxic free light chain chains can be removed via plasmapheresis or high cutoff dialysis. So this high cutoff dialysis has significantly larger pore size than the normal high flux dialyzer of light chains. However, this has to be there in conjunction with the chemotherapy to suppress the production of the light chains. However, the benefit of this extracorporeal free light chains has not been established. Only in the hyperviscosity syndrome, plasmapheresis has been found to be effective. The recent 2 trials, which is the ULAT trial from the European group, didn't show any significant improvement in the quality of life, nor showed any significant dialysis independence at 3 months. So it has not been well established. Transplant in patient with end-stage kidney disease on dialysis with myeloma is possible. Achieved a stringent and correction. The experience is limited to few case report and series, and they have showed that survival is between 1 year to 8 years. So to conclude, kidney disease is the common combination of myeloma and wide manifestation involving different components of the kidney, and 50% patient can present a kidney to nephrologist. And there may be monocular grammopathy of undetermined significance presenting with renal involvement, giving rise to MGRS. And as this can be involvement of all the components, giving rise to glomerular involvement, tubular involvement, interstitial light abnormality. So there should be a high index of suspicion, and there should be a team approach for the same. So once upon a time, it was said that syphilis, if you know the syphilis, you know the medicine. Similarly, and diabetes, because they are multi-system disorders and affect virtually all the system of the body. So today I would like to say, if you know the myeloma, you know the nephrology. Thank you.
Hello.
Yeah.
This is Dr. Santosh Kadam. Friends, we are felicitating Sri Vivekji Phansalkar, Commissioner of Police, Thane. Welcome, sir.
Namaskar.
Friends, please welcome Sri Vivekji Phansalkar, Commissioner of Police, Thane. We are privileged to have with us today for the felicitation program. We are felicitating him for his work by giving the COVID Champions Award as an COVID warrior. Friends, let me tell you, sir led from the front for containing COVID pandemic in Thane jurisdiction, Thane Commissionerate jurisdiction, I'll say, including Thane City, Kalyan, Dombivli, a lot many corporations come under his jurisdiction. We can definitely control in Thane district this COVID pandemic because of his iron hands. It was very difficult for containing. At the same time, there was a lot of anger in the society as soon as this lockdown was implemented. So that time also, sir swiftly handled the law and order very well. Friends, let me tell you, sir has a lot of medical knowledge. We used to discuss in detail. Even he knows how remdesivir works. We used to discuss what is the role of steroids. Whenever his staff was admitted, he used to coordinate with me, and we used to coordinate with the respective hospital regarding the treatment, whatever is going on and progress and all these things. Even he called whenever a few known doctors to him were admitted, he was inquiring with me how he is doing. So he was so concerned about even doctor fraternity. He 2-3 times raised the question that doctors should not catch up infection. Do whatever needed by giving protective gears to them. Friends, in the month of April, when this lockdown was declared, and as there was a lot of fear in the society regarding this COVID, even we people, doctors and the service provider, essential service provider, healthcare workers are being ostracized by this society because of the fear of corona. Many doctors were not allowed to come into their societies. They were not being allowed to park their vehicles. And same was the thing with their clinics and hospitals also. But that time, sir came to our help. He rescued us through his GCP, and he used to talk to the society. We are very grateful to him. We are very indebted to him. Me and sir met in various meetings for last 9 months. He used to attend all the meetings related to control of corona pandemic. One at when our honorable CM attended in Thane Municipal Corporation. Today I am presenting this trophy. Aditya, can you show me the trophy on the screen? Sir, this is the trophy prepared for you specifically. We are going to come to your office with my entire team. I know there's a we cannot come in more than 5. Maybe we will stand outside and come in a number of 4 and present to you. This is the physical trophy. Sir, please accept this trophy
Thank you.
from my
Thank you
entire
very
team.
much. Thank you very much, Dr. Santosh Kadam. Thank you.
Sir, over to you. I will request you to address my doctors. Sir, we have today not only doctors from Thane, but from entire Maharashtra. They have joined for online CME, sir.
First of all, I would like to welcome the entire medical fraternity that is present for the conference. Today, the initiative of IMA Thane is extremely laudable. I also listened to Dr. Aniket. He was presenting some case of a diabetic lady, saying so many parameters, which finally I thought will become difficult to digest. And congratulations, Dr. Aniket, and to all doctors who are presenting today for the benefit of all other colleagues. Let me be very honest in my thanking the Indian Medical Association Thane, especially Dr. Santosh Kadam, Dr. Vidya Kadam, his wife, and many other doctors whom we interacted with during this very difficult period of COVID, which the country, the society, and the world together faced. I have no qualms in saying that the medical fraternity and the health workers, be it nurses, ward boys, even pharma companies who took great efforts to provide medicines like remdesivir and other necessary for curing this menace. You all have done a very, very great job, and no amount of thanks will be enough to thank all of you. We also pitched in because you know how difficult it is to manage our society, how difficult it is to convince them to be indoors, especially when they don't feel the pain. They would always say, "Amala kai dhal nahi, amala kashala thambota." And there were areas where we had to do constant confrontation. We tried to convince them most of the time to help the municipal authorities for the surveillance and the survey were conducting large numbers. And the amount of work that you people did is simply phenomenal. The society is and should be deeply indebted to you. And now we see figures that are going down. There was a day, Dr. Kadam knows, when my 232 policemen on a single day were in hospital.
Yes, sir.
One hospital or the other, difficulty finding beds. A large number of citizens also. Today, the number has reduced significantly. In my force, only 16 people are admitted today. None of them is serious. None of them in ICU. None of them needing remdesivir or tocilizumab. So all this is thanks to the doctors and the medical fraternity. It is to acknowledge the role of police, and as a leader of the force on behalf of the entire police force, with great humility, happiness and joy, I accept the trophy that you have presented me today. Doctor said that he is going to come. You are most welcome to my office for a cup of tea along with the trophy, and I assure you that not just 5, but whoever comes with you, we will try and accommodate them.
Thank you, sir. Thank you.
The social distancing standards.
Yeah.
I once again thank all doctors who are present here for their time and for this recognition. It means a lot to me. Thank you very much. God bless all of you.
Thank you. Thank you, sir, for sparing your time and coming. Sir has a family function. In spite of that, he joined. And your word for entire Dr. Fraternity is an award for us. Thank you, sir.
Thank you.
Thank you very much, sir.
Thank you.
Over to you, Rahul. Over to you, Rahul Bapat.
Our next participant is Dr. Dipanjan Haldar. I request Dr. Jayanti Bhate to introduce him.
Yeah, hello. No, anybody wanted to ask any questions to Dr. Aniket? Then we can continue with the next talk maybe. Or we'll start the next talk. Dr. Rahul?
Yeah, we'll start.
Yeah,
We'll start. Okay. Dr. Rahul has already introduced Dr. Dipanjan Haldar, but I'll again like to introduce. He is a consultant of hematology and bone marrow transplant at Wockhardt Hospitals from before and now at Jupiter Hospital since May 20. And after his first talk on the treatment of a freshly diagnosed multiple myeloma patient, now he's going to talk about bone marrow transplant, the how to go about managing these patients and how to carry on. Dr. Dipanjan?
Thank you, madam. Thank you for the kind introduction. I once again thank the IMA for giving me this opportunity. So my next talk is going to be about basics of bone marrow transplant. And thank you once again, the IMA, for giving me this opportunity. Thank you, Dr. Santosh Kadam, sir, Dr. Rahul Bapat, sir, and madam for the kind introduction. My next talk is about the blood and bone marrow transplant, the basics and what you need to know. So bone marrow transplant, as the name sounds, it often sounds very high fundu, something very scary. And so I just thought I'll discuss with you and the brief basics about the bone marrow transplant and just the overview of the procedure, what we do, and the last but not the least, a few of the medico-legal aspects of bone marrow transplant as well. Plus, often there is confusion about what is stem cell therapy, what is bone marrow transplant. So I'll just touch upon that topic as well. So I'll cover my talk under the following headings: a brief history of bone marrow transplant, transplant types, source of stem cells, from wherever we can get the stem cells for bone marrow transplants, indications, what are the diseases where we do in the bone marrow transplants, transplant process. So the transplant process, the actual transplant process is broken down into various procedures. That is the conditioning chemo, stem cell infusion, neutropenic phase, engraftment phase when the patient's counts actually recover, the post-engraftment. So once the counts recover following the bone marrow transplant, what all complications we can get, and various cost and complications of the bone marrow transplant, as well as few of the medico-legal aspects. So brief history about bone marrow transplant. So Sir Donald Thomas is the one who first described this procedure from Fred Hutch Cancer Research, Washington, USA. And I was quite fortunate enough to have trained in the same institute for bone marrow transplant. And Sir Donald Thomas was awarded a Nobel Prize for this in the year 1990. Type of transplant. So the bone marrow transplant, it is called as autologous bone marrow transplant, wherein we use the patient's own stem cells for carrying out the bone marrow transplant procedure. Or it can be allogenic bone marrow transplant, from where we use the donor for obtaining the stem cells. So depending on the donor, it can be sibling allogenic transplant. It can be unrelated donor, so wherein we get the donor, HLA matched donor from the registries. And it can be parent or relative, which can be matched versus haplo. So haplo or half matched transplant, in wherein we use a father or a mother of a patient, wherein, or a brother of a patient, wherein the donor is half matched. So HLA wise, it is half matched with the patient. Or it can be umbilical cord blood transplant, where we obtain the stem cells from the umbilical cord blood. So what about the number of transplants? The number of transplants done per 10 million in developing countries is more than 300, whereas for in India, for a population of 120 crores, we should be doing about 36,000 bone marrow transplant per year. What we are actually doing is about 600 to 700. So you can see the huge gap between the patients who are needing bone marrow transplant and the patients who are actually getting the procedures done. And why is this gap there? This gap is there because of many issues. Number one is, of course, the cost. Plus, then there is the lack of technical expertise. So there are many physicians or many even hematologists who are not comfortable doing the procedure, and lack of facilities. So very few hospitals across the country are equipped enough to support the bone marrow transplant infrastructure. At Jupiter Hospital, we fortunately have a fully developed bone marrow transplant unit. So of this transplant, about 60% are allogenic and 40% are autologous, where we use the patient's own stem cells. So wherein can we get the stem cells? So the stem cells, we from the source wise, we can harvest is from the bone marrow stem cells. So this is done in the OT, where we harvest the bone marrow from the posterior superior iliac spine and use this as a source of stem cell. More oftenly, we use the peripheral blood stem cell, as I just showed you in my previous lecture also, where we give the patient growth factor and plerixafor, bring in the stem cells from bone marrow to the peripheral blood, and hook up the patient to a apheresis machine. So in Jupiter, we have a Spectra Optia machine. So what this machine does is it collects the stem cells, it separates the stem cells from the patient's blood and returns back the rest of the blood to the patient or the donor. And these stem cells then we use for the stem cell transplant or bone marrow transplant procedure. Alternatively, we can get stem cells from the cord blood as well, but cord blood stem cells are not very frequently used because of many technical issues. So the stem cell dose that we get in from cord blood is often not quite less, and it's often inadequate to carry on the bone marrow transplant procedures. Often we need 2 or more cord blood units, plus there are various other complications with cord blood transplant as well. So who can be a marrow donor in HLA in an allogenic transplant? So in allogenic transplant, we need a HLA matched donor. So what is HLA? HLA is basically human leukocyte antigen typing. So just to going back to our pathology classes, so the HLA locus is actually present on short arm of chromosome 6. We have class 1 HLA, which is A, B, and C, and class 2, that is DP, DR, and DQ. So we match the donor and the recipient in terms of HLA, and if the HLA is matched, then we can use that donor for the recipient. So best allogenic blood or bone marrow donor is obviously a matched brother or sister, but only 25% of patients are that lucky, and there is only 1 in 4 chance that any child will match another child of the same parent. The formula being 1 minus 3 by 4 to the power n. I'll be elaborating this further. So in 1% of cases, a parent may be a donor because of shared HLA types between both the parents. So the major obstacle for allogenic transplantation is obviously a matched availability of a donor as well. So how to see the probability of getting a matched sibling donor? So suppose there are 1 sibling, then we use this formula 1 minus 0.75 to the power n. So then there is 25% probability that that sibling will be matched for the patient. So if on the other end, if there are say 7 siblings, so this comes down to 0.87. So the more the number of siblings, the more of the probability of finding out a matched donor in the same family. So what are the strategies to overcome this problem? So to overcome this problem, we have various strategies. For example, there are donor registries. For example, in US we have the National Marrow Donor Registry Program. We can use the umbilical cord blood, or we can use partially matched donors, which we call as the half-matched or haplodonors. Whether we have any registries in India? Yes, in India also we have Marrow Donor Registry of India, as well as DAT3. So blood stem cell donor registry. So we have these 2 registries in India, which are doing quite a good job for providing marrow donors for unrelated marrow donors for patients suffering from serious blood disorders. So now coming to the diseases or indications that we transplant. So autologous bone marrow transplant. So autologous bone marrow transplant, here we use the patient's own stem cells. I'll be elaborating the procedure further, but what are the diseases where we do the autologous bone marrow transplant? The autologous bone marrow transplant we do for bad lymphomas, for example, relapsed Hodgkin's lymphoma or relapsed non-Hodgkin's lymphoma. We do it very commonly for multiple myeloma. So the patient which I just showed in my first presentation, for patients who are in remission post chemotherapy for multiple myeloma, we proceed with autologous bone marrow transplant. Rarely for pediatric patients also, for stage 4 neuroblastoma, we do autologous bone marrow transplant. What about allogenic bone marrow transplant indications? So the allogenic bone marrow transplant is the transplant wherein we get the stem cells from a donor. That is the patient's stem cells we are not using, but we are getting the stem cells from a donor. So what are the diseases where we do allogenic bone marrow transplants? We do it for various malignant diseases, for example, acute myeloid leukemia, acute lymphoblastic leukemia, various such kind of blood cancers. We do allogenic bone marrow transplant. We did for various metabolic disorders, for example, all these rare storage disorders, adrenoleukodystrophy, Hurler syndrome. So these patients need allogeneic bone marrow transplant. For various inherited immunodeficiency disorders, for example, severe combined immunodeficiency, Wiskott-Aldrich syndrome, and so on and so forth, we do allogeneic bone marrow transplant. For various inherited red cell disorders, the most common being thalassemia. So for such patients also, we do allogeneic transplant. That means we get stem cells from a donor. And for various marrow failure states, for example, severe elastic anemia, Fanconi anemia, and others. So now coming to the transplant process per se, I won't be going into the details, but just to give you an overview, what we mean by bone marrow transplantation, what we actually do. So this procedure is broken down into five parts. That is conditioning, stem cell infusion, neutropenic phase, engraftment phase, and post-engraftment period. So just to show you an overview of autologous bone marrow transplant. So an autologous bone marrow transplant, what we do, we collect the stem cells from the patient. So before collection, as I mentioned, we give growth factors and stem cell mobilizers, that is plerixafor, to the patient. So this, what it does is it brings the stem cells from blood, from bone marrow to the blood. So we hook up the patient to a machine, and the stem cells get processed, and these stem cells we collect. So these stem cells we can use it immediately after giving high dose chemotherapy, or these stem cells we can cryopreserve. So cryopreservation is wherein we mix this with a substance called as DMSO, and we keep these stem cells, we can preserve in -80 for years together. And during when we need to use these stem cells, we thaw these stem cells and we reinfuse. That is, we infuse the stem cells back to the patient, just like blood transfusion. So just showing the procedure in slightly more detail. So the patient is actually given growth factors for 4 to 5 days. The patient is connected to a machine, the apheresis machine, and then we we collect the stem cells from the blood through this machine. This, for immediate use, it can be stored at 4 degrees centigrade, or if you're planning to use it later, it can be stored at -80. So this is an example where you're using this for immediately for a patient of multiple myeloma. So once we have collected the stem cells through peripheral blood harvest, we have kept this under 4 degree. We ensure that the stem cell collected, the dose of stem cell collected is adequate, and then we give the patient very high dose chemotherapy. So why we give this high dose chemotherapy? The purpose is basically we expect that the small amount of cancer that is remaining after the initial cycles of chemotherapy, we expect that to be killed by this very high dose chemotherapy. But this high dose chemotherapy, in addition to killing these cancer cells, what it does is it completely kills the normal bone marrow. So if the normal bone marrow is killed, we won't be having any blood, or blood cells won't be getting formed. So what do? So we infuse back the stem cells which we have already collected. So we infuse back the stem cells, and these stem cells slowly it starts forming the patient's marrow. So it takes about 2 to 3 weeks time for the stem cells to start forming the patient's marrow. So this was about autologous bone marrow transplant. What about allogenic bone marrow transplant? So almost similar procedure, but in allogenic bone marrow transplant, we use a donor from wherein we collect the stem cells, and the patient, we give the patient very high dose chemotherapy, and followed by infusion of the stem cells to the patient. So again, showing it in further slightly more detail. So here the sister is donor. So the stem cell, so we select a donor from the family. We do the HLA typing, as I showed you. We do the HLA typing of the patient as well as the donor, and whoever is the HLA matched to the patient, we select that person as a donor. If no one is HLA matched, we get the donor from unrelated donor registries. So in this, we give the growth factors to the donor, and we collect the stem cells. Same procedures just like for autologous transplant. What do we do to the patient? We give the patient very high dose chemotherapy plus minus radiotherapy, and then we infuse the donor stem cells to the patient. And post-transplant, about 2 to 3 weeks, the stem cells gradually form the patient's marrow, and the patient we expect to recover. So a few quick facts about bone marrow transplantation. So what are the hematological diseases that may require bone marrow transplant? So I've already described this: leukemia, lymphoma, myeloma, myelodysplastic syndrome, bone marrow failures, thalassemia, sickle cell disease are some of the diseases where we use bone marrow transplant. What are the sources of hematopoietic stem cells? So the hematopoietic stem cells can be harvested from matched, related, or unrelated donors, or a matched sibling donor, so what we call as allogenic transplant, or patient's own tissues, what we call as autologous transplant. From the source per se, it can be classified as bone marrow harvest, blood harvest, or umbilical cord blood stem cells. Common post-transplant complications. Why is bone marrow transplant such a sophisticated procedure? Because the patients become very critical because of very high dose toxic chemotherapy that we give to the patients, or there can be graft versus host disease. So what is graft versus host disease? So as I mentioned, in allogenic transplant, what we do is we use the donor stem cells. So the donor stem cells, in spite of being HLA matched, they can go and attack the patient. So specifically, they most commonly attack the patient's vital organs, for example, the liver, the skin, and the intestines. So this leads to something called as graft versus host disease. So wherein the patients can have profuse diarrhea, or wherein the patient's skin can get completely denuded, just like a burns patient, or wherein there can be severe hepatic dysfunction. So this is called as graft versus host disease. There can be various infections post-transplant because the patient is quite immunosuppressed, and because of the very high dose chemotherapy that we give makes the patient susceptible to infection. And very rarely, so required rarely, there can be often relapse of the underlying disease as well after the bone marrow transplant. So what are the side effects of growth factors that we use? So really the growth factors can cause bone pain, muscle pain, or headache. So what specifically do I need to do during mobilization? So mobilization is basically the process in which we collect the stem cells. So daily blood draw. So we keep giving the injections daily, and we check the stem cell count on the peripheral blood to see whether we are getting adequate number of stem cells. What are the side effects of apheresis? So apheresis is the procedure, what I told is when we connect the donor to a machine and we collect the stem cells. So we need to insert the patient a venous catheter, basically central venous catheter, prior to this apheresis procedure. So probably this is the only uncomfortable part. The apheresis procedure itself is painless. So it is just like platelet donation, almost similar procedure. So sometimes patient can get some side effects because of hypocalcemia. So chilling, slight tingling, numbness, and mostly limited to that. Adverse reactions are quite uncommon. So very often prior to bone marrow transplant, we use this, we insert a central venous line, what we call as Hickman lines, which we also use prior to chemotherapy. So this we can use for giving the patient high dose chemotherapy, blood transfusions during the neutropenic phase, because these patients require quite a lot of supportive care. So now coming to the conditioning phase. So what is conditioning? Conditioning is the very high dose chemotherapy plus minus radiotherapy that we give the patient. So typically this lasts for 7 to 10 days in allogenic transplant. So what is the, I mean, why we need to give the patient very high dose chemotherapy plus minus radiotherapy prior to transplant? The purpose is basically to eliminate the cancer if the patient is suffering from malignancy, as well as to provide immunosuppression so that the patient does not reject the donor stem cells, and to empty the marrow so that there is space for the new stem cells which are coming in. So these are the threefold purpose for giving the conditioning regimen prior to bone marrow transplant, and radiation and chemotherapy agents differ in their abilities to achieve these goals. So for example, this is typical conditioning regimen where we give high dose busulfan, high dose cyclophosphamide, and ATG prior to bone marrow transplant. So what is stem cell processing and infusion? So stem cell processing is, the procedure is almost similar to just, it looks like blood transfusion. The procedure can last for 20 minutes to an hour, and it varies basically depending on the volume infused. Very rarely we can even do depletion of T cells to decrease the graft versus host disease effect. Pre-medication prior to stem cell infusion, almost similar to what we give prior to blood transfusion often. So just plain paracetamol and Avil injection to prevent any kind of reaction. So just procedure of stem cell infusion growing. So this just looks like blood transfusion. So this is the patient suffering from thalassemia who is receiving a stem cell infusion from one of his matched sibling donors. So the stem cells are infused to central venous line just like blood transfusion. Very rarely there can be some side effects, for example, anaphylaxis, volume overload, and rarely transient graft versus host disease. The stem cells, in case they are cryopreserved, there is an additional medicine, that is additional chemical that we use, what we call as DMSO. And this can rarely cause renal failure, and it per se itself has an unpleasant, like garlic kind of smell and taste, so which might be uncomfortable for some of these patients. So what happens to the stem cells once we infuse them? So these stem cells through the blood, they migrate to the bone marrow, and they go and home themselves in the bone marrow. So this is basically called as homing. So the stem cells through the blood, they go and migrate themselves and settle down in the bone marrow. So this is what I was talking about. So the very high dose conditioning regimen or the chemotherapy regimen that we give prior to bone marrow transplantation, it brings down the white blood cell count and the platelet count drastically. So this makes the patient quite immunosuppressed. The blood cell counts drop down. The patient needs to be kept in a specialized HEPA filtered room, and where even the air entering the room is filtered. And gradually, once the stem cells engraft, the blood counts gradually start to improve, which takes about 2 to 3 weeks, and gradually the patient starts to feel better. So this is this peak period of neutropenia that predisposes the patient to all infection-related complications, and this is often the most challenging period of bone marrow transplant procedure. So the neutropenic period, this typically lasts for 2 to 4 weeks. The patient effectively does not have any effective immune system during this procedure. Healing is extremely poor. Patient is suggested to all sorts of infection, bacterial, fungal, viral infection, supportive care, and we need very high dose antibiotic, antifungal for this phase. So post this, we give the engraftment phase. So what is engraftment? Engraftment in simple language means recovery of the white blood cell and the platelet count. So during this period, which lasts for several weeks, the healing process actually begins and the resolution of mucositis. So there is often the patient gets very severe mucositis wherein they are not able to swallow food. They get severe diarrhea, nausea, vomiting. So this phase, in the engraftment phase, all this gradually starts to healing. Fever gradually begins to subside, the infections begin to clear. And the greatest challenge at this phase is graft versus host disease and the prevention of viral infections, especially cytomegalovirus. So the graft versus host disease, as I told, is basically the donor stem cells attacking the patient's body. So the patient is basically kept isolated. All the food that we give to the patient is terminally pressure cooked. The patient is usually kept in HEPA-filtered room wherein a strict disinfection procedures and protocol for microbiological surveillance is maintained to maintain sterility of the room. So all the blood and blood products that we give to the patient during this phase is also irradiated to prevent transfusion-associated graft versus host disease. And then we get something called as a post-engraftment phase. So what is post-engraftment phase? So this phase basically lasts months to years. So in this phase, the hallmark is gradual development of tolerance, wearing off of the immunosuppression and management of chronic graft versus host disease and documentation of immune reconstitution. So everything basically starts to improve. The patient's immune system becomes normal. So it might take 6 months to even 1 year. So a bit more elaborating about graft versus host disease. So donor cells, they see the host cells as foreign, and then the donor cells will attack the host. So typically, these are the most common organs that are affected: skin, gut, and the liver. So we correlate acute graft versus host disease where it occurs immediately after transplant, that is less than 100 days, and chronic graft versus host disease if it occurs after 100 days. So the risk factors could be HLA mismatch, presence of lymphocytes in the graft, and inadequate immunosuppression. So herein I show you some photos of the skin graft versus host disease, wherein it looks like scleroderma, wherein the patient gets so chronic graft versus host disease. Very often in acute graft versus host disease, it can just look like a burns patient, wherein the complete skin can get denuded and fall off. So grade 4 skin graft versus host disease, wherein the complete epidermis has kind of got denuded and we get this kind of blisters. And this is like chronic extensive graft versus host disease. So this is chronic extensive graft versus host disease of the skin, which looks like scleroderma patients. So other problems encountered, we often get various other problems as well. For example, hemorrhagic cystitis because of the high dose chemotherapy that we give to this patient. We give veno-occlusive disease of the liver. There could be serious organ toxicity involving to the lung, heart, and kidneys. Very often the lungs are also involved in something called this idiopathic pneumonia syndrome. Just to show you a few pictures, so very bad oral mucositis where the patient has developed bad ulcers over the tongue and the oral mucosa, candidiasis of the mouth, again some mucositis of the lips and the gums. And often these patients are quite immunosuppressed, so they develop bad fungal infections. For example, aspergillosis, this patient has developed. So briefly about medical legal aspects of bone marrow transplantation. What about like whether it is covered under the Organ Transplantation Act? What is stem cell therapy versus bone marrow transplant procedure? So in India, the transplantation of organs is covered under the Transplantation of Human Organs and Tissue Act. So this I have taken from Indian Journal of Transplant 2018. So the stem cell or the bone marrow transplantation is actually not covered in the Transplantation of Human Organ and Tissue Act. So what is covered is kidney transplantation, transplantation of liver and the other abdominal organs, cardiac, pulmonary and cardiopulmonary transplantation, cornea transplantation. So it is quite an elaborate document wherein they have laid down quite elaborately about even the qualification of the persons required to doing these procedures. But just to, give you an overview, bone marrow transplantation does not come under Transplantation of Human Organ and Tissue Act. So what is stem cell therapy and what is bone marrow transplantation? So stem cell therapy is actually an experimental therapy which is employed for various other, various diseases, for example, stroke, amyotrophic lateral sclerosis, muscular dystrophy, liver cirrhosis, kidney cancer, to diabetes, Crohn's disease. So all these are potential uses of stem cells. But when we are talking about bone marrow transplantation, we are not talking about stem cell therapy. So this is quite, I mean, they have laid down the regulations quite clearly. So as per the national guidelines for stem cell research, at present, there are no approved indications for stem cell therapy other than the hematopoietic stem cell transplant for hematological disorders. Very recently, US FDA has approved osteoclastic stem cell for treatment of avascular necrosis of hip joints. But apart from these two indications, there are really no approved indications for stem cell therapy. So this has been also laid down in national therapeutic uses of stem cell guideline. So wherein they have laid quite extensively that no approved indications for stem cell therapy other than those listed for hematopoietic stem cell transplant. And they have laid down the indications which I've already kind of described. So basically all kind of blood cancers, bone marrow failure syndromes, again, blood cancers, thalassemia, immunodeficiency disorders. So all these are various indications where we can do the bone marrow transplant. So often I'm asked about the cost of bone marrow transplant. So the cost of bone marrow transplant in India is actually quite low compared to the Western countries. So in US, you can see that it costs more than $100,000. Whereas in India, about $15,000, which roughly comes down to about 8 to 9 lakh rupees for bone marrow transplantation. So in spite of all such risks and all such complications that I describe what is the rewards of bone marrow transplantation. So it is basically employed for life-threatening disorders. For example, in this case of child of Viscott-Aldrich syndrome, such case of thalassemia, blood cancers. So for which the patient will actually not survive without bone marrow transplantation. We do this procedure, and often the rewards are quite humbling, and the procedure itself is quite gratifying. So with that, I'll be happy to take up any questions. I know this is quite an extensive topic, so I've tried to cover in brief and give you just an overview of the procedure.
Dr. Dipanjan, I think you have covered quite the topic pretty well. If anybody has any questions, you can put up in the question answers box. We have a question, but it apparently is not very related to this topic. Anybody has any questions?
Let Dr. Pingolkar welcome Dr.
Yeah. Okay, fine.
So I'll be happy to take up the question that I think Dr. Tejas Shinde has put up. So regarding treatment of HIV with bone marrow transplantation. So yes, I agree with you completely. There was a medical literature about this a few years back. So this is not routinely employed, but so this was actually quite an accidental discovery. So wherein they used a donor, so they used a HLA matched donor, but this HLA matched donor had was CXCR4 mutant. So the HIV virus, it requires these receptors for getting into the patient's immune system cells. So so accidentally the HLA matched donor in this case was CXCR4 mutant, and so it was discovered the post bone marrow transplant procedure that the patient has now got cured of the HIV infection. Okay. So wherein they went back and then they analyzed the donor stem cells. And then they realized that the donor is actually CXCR4 mutant, and that is the reason why the patient has got cured of the HIV infection. So this was an accidental discovery, but such mutants are quite rare, and definitely this is not a routinely employed procedure to get rid of HIV infection.
Thank you, Dr. Dipanjan. Yeah, thank you very much.
Dr. Sanjay Pingulkar here, Vice President of Thane IMA. On
Hello,
behalf
sir.
of Thane IMA branch, I welcome Dr. Dinkar Masde, who is an observer today from MMC. Welcome, sir.
Yeah. Welcome, Dr. Alba. Well, no need for introduction for Dr. Alba. She is a well-known, renowned pulmonologist in the city of Thane, and she is a HOD in Pulmonary Medicine Department in Jupiter Hospital. She has got multiple presentations to her credit, maybe more than 150 or so, and publications as well. She has got special interest in holistic rehabilitation of patients with chronic respiratory diseases. She is involved in holistic approach since quite a long time, and in Jupiter she has her own separate department where she is heading that also. So apart from the scientific approach, she goes ahead with this holistic approach also. I welcome her for this presentation. Welcome, madam.
Yes, thank you, Kamlesh, for the kind introduction, and thank you team IMA, Dr. Santosh, Dr. Sanjay, Dr. Rahul, Dr. Jayanti, all of you for taking this wonderful initiative. And it was a very good feast indeed for everyone. So today I'm going to talk on the topic now, which is becoming very important. And as fortunately the incidence of COVID is coming down, we are seeing more and more cases. We are lingering with symptoms. what we are calling as long COVID or post-COVID syndrome. And as we are seeing more and more patients, we need to develop more understanding into this subject as to how to help our patient to recover and get back to their normal life. So this is what is my topic today, post-COVID care and importance of rehabilitation. It's actually a very extensive topic. We can have a half a day CME itself on this topic, but I'm going to try and briefly cover up the points. What are the issues and what can you manage in your clinical practice? And when do you want or when do you need to refer the patient to a specialized post-COVID clinic? So this is what we are going to touch upon today. What is post-COVID syndrome? What is the incidence and what is the timeline, till what timeline it stretches? What are the different severities of post-COVID syndrome, different clinical presentations? And then coming to rehabilitation, what are the different components of post-COVID rehabilitation? And what are the needs which patient need this comprehensive approach, and the benefits and evidence and our experience. So post-COVID syndromes, many patients continue to experience symptoms related to COVID-19 after the acute phase of infection. But currently there is no clearly defined consensus definition for this condition. It is evolving. It has been called with various names like long COVID syndrome or post-COVID syndrome, long haulers, or chronic COVID-19. It's actually a spectrum of different severities, and important thing to realize is that they need evaluation. Even sometimes some of the studies have shown that patient having mild or initially asymptomatic patient also sometimes tend to develop these symptoms during the recovery phase. So it definitely requires evaluation. It requires management for persistent symptoms or onset of new symptoms. So they need guidance, reassurance, and rehabilitation. So this was one very good study which was published in October in Clinical Microbiology Journal. So here we can see 150 young patients. These patients were very mildly symptomatic and they had not required any hospitalization. They were managed only on OPD basis, and they were evaluated for presence of symptoms while they were acutely ill, and then after 1 month and after 2 months. So patients having almost 100% of patients were having one or the other symptom. But what was important to see that even on day 30, almost 68% of the patient had at least one symptom lingering, and that was 66% at day 20. So even for apparently healthy and mildly symptomatic subjects, almost 2/3 of the patient were experiencing at least one symptom at the end of 2 months. And anosmia or loss of taste were very common symptoms which were present 28 to 23% of the patient by end of 2 months. Breathlessness, which was initially 56%, that persisted in 36.7% and 30% of the patient, and asthenia. Post-COVID asthenia, important symptoms, and a lot of our patients, maybe more than 50% of our patients present with post-COVID asthenia. And here you can see, even they have not recovered. 40% of the patients are not recovered by day 60. So now this is emerging as a very important clinical spectrum. So what are the symptoms that the patients of post-COVID are present with? So there are physical symptoms, and the commonest symptoms that patients of post-COVID have is fatigue. And in various studies, it has been reported depending on the various severity and the population. 15 to 87% of patients have fatigue. 10 to 71% patients have breathlessness. Chest pain or tightness is also very common symptom. Many of you would have noticed your patient coming back with some vague symptoms of feeling tight or feeling heavy in the chest, or at the time of when they are breathing, they feel the chest is not expanding well. These kind of vague symptoms, and sometimes we feel that it may be just psychological, but no. Number of studies have now shown that the chest tightness and chest pain is a very important lingering symptom in the post-COVID symptom. Cough, dry cough is a very common symptom. And if the patient develops productive cough, especially if they have been taking long-term steroid, then you must be aware of some opportunities infection or secondary infection. But majority of the patients who are not secondarily infected, dry cough is a common symptom. And we've also seen that people who have asthmatic tendency or atopic tendency with this viral infection, they have unmasking of asthmatic tendency, or they also develop new onset acute bronchitis, and these people do well with inhaled corticosteroids. Then loss of smell, taste, and appetite also lingers for a pretty long time, sometimes for 2 months or 3 months, patients do not recover, and that affects their food intake and nutritional status. Then other minor symptoms like myalgia, arthralgia, hair loss, headache, rhinitis, dizziness. Insomnia also has been emerging as a very important symptoms, and many of my patients, many of my doctor colleagues have said that their sleep gets extremely disturbed. Either they have problem with initiation of sleep or maintenance of sleep, and excessive sweating. So these are the common physical symptoms that patients present with. Then a lot of psychological or cognitive symptoms, and it's been realized that compared to other flu-like illnesses, recovery of flu-like illnesses, COVID-19 has got a different spectrum of, and it is much more impacting the psychological and cognitive functions of patients who are recovering. So post-traumatic stress disorder is very common, especially if patients have been hospitalized, they have been isolated, patients have been hospitalized in ICU, or have needed mechanical ventilation and long hospital stay. These patients keep getting images and thoughts of their hospital stay, and they this is a quite serious condition they suffer from. Then worsened memory and concentration. So many of them are not able to get back to their work because of their affection of the memory and concentration. Anxiety, depression, restlessness, fear of getting the infection again, fear of not recovering or going back to the normal level of activity. All these are psychological impacts of COVID. So what is the recovery timeline that studies have reported? So expected recovery time actually depends on various factors. That what was the severity of acute COVID syndrome? That's one of the most important factor which decides the recovery timeline. And the age, elderly obviously do much worse than younger patients. Patients having pre-morbid condition, multiple pre-morbid conditions. So we've commonly seen diabetics, especially uncontrolled diabetes, or patient having previously a respiratory issue. Like one of my patient who had, she was having interstitial lung disease, a young patient. Everybody in her at her home got infected and they recovered very well, but she had worsening of the hypoxia. She lost a lot of muscle mass and she took almost about 3 months to recover. So we have seen that patients who have got existing comorbidities, they take much longer and they need much more assistance and rehabilitation. And she was in a COVID facility where, unfortunately, they are so much overloaded with workload that they don't have facility for rehabilitation of this patient. And sometimes patients do not know where to go and whether to go back to their primary physician or to seek help regarding this recovery in this recovery phase. And then when she contacted us, we started her on tele-rehabilitation session, and after 12 sessions, she had become so moribund that she would not even sit in a bed to eat. And a lot of psychological impact. She had a lot of post-traumatic stress disorder. And when we started her on rehab session, tele-rehab session, because she could not come to the facility, after 12 sessions, she started doing her independent work. She gained confidence. And so this is how the recognition of severity of your post-COVID syndrome and taking the right interventions are very important. Patients who stayed in the hospital for a long time, they will take longer to recover when they lose a lot of their muscle mass. Their nutrition also is very poor. So all factors like ICU stay, mechanical ventilation, nutrition, whether rehabilitation was initiated while they were in the hospital, that also has a big impact. And having realized that, we have started initiating our patients on rehabilitation while they are in the hospital itself. And so we also have started concept of doing inpatient tele-rehabilitation, because many times we don't want to expose our physiotherapist or our staff to these patients. So we start online session while they are in the hospital itself. And patients who develop new onset complication, and this is also very common. We've seen patient developing diabetes, or patient developing cardiac condition like congestive heart failure, myocarditis, or some neurological issues, and infections are also very, very common, especially when they have received higher dose of steroids or tocilizumab. So these are when these patients develop infective complication that really hampers their recovery. So what are the severities and different clinical presentations? So patients who have mild COVID-19 and who do not have many premorbid conditions, up to 30% still experience symptom beyond 3 weeks. So symptoms could be fatigue, breathlessness, chest tightness, cognitive deficits, or psychological effects, and this can go on for 2 to 6 months. So what are the corrective measures? So these patients who got mild symptoms, they've never required hospitalization. Now, these are the patients who very well can be managed on OPD basis in your clinical practices. It's just that you need to be aware of these symptoms and you need to guide them about right intervention. So first of all, reassurance is very important, because many of these youngsters who come to our OPDs and they have all these symptoms and they start getting a lot of self-doubt and they start getting depressed, because even after having a mild disease, they're somehow not able to get back to their routine level of activity. And these are young people who want to just get back to their normal level of functioning as soon as possible. And the other day, one young doctor had come to me. He was a surgeon and has been used to doing surgery for 10, 12 long hours. So mild symptom, but even after 3 weeks, he didn't feel confident to get back to his normal level of activity. And he said that really made him very anxious and depressed at whether it's going to affect my career. And these are the issues people face. So I had to counsel him, give him a lot of reassurance, just advise him to change the diet, usually advise them to take on antioxidant rich diet, then light stretching exercises, which is what they start with, and adequate sleep. That's very important, because many times what happens that is people then trying to catch up with the work and they try to spend long hours, long screen time, and they don't focus on the sleep. And then we started giving him gradual incremental exercises with the help of our physiotherapist. And so that really helped him to get back to his normal level. And it's very important to tell your patient that just out of anxiety to get back into normal level, don't push them. They should not push themselves and jump into activity levels before they have recovered. That can be quite counterproductive. Group therapy also has been advocated for this patient, because when they meet people with similar kind of symptom, they feel really reassured. So if social distancing is an issue, this group session can also be arranged online. So when you have been managing your COVID patients, or you're managing either on OPD basis or you've been managing in COVID centers, what is generally advocated as a timeline for follow-ups? So healthy patients usually who have had mild or no symptoms probably may not need a follow-up unless they develop any symptoms. The patients who got mild to moderate acute disease, elderly, or having presence of comorbidities, but they had not required hospitalization, then it is advised that their follow-up should be arranged within 3 weeks of their first symptom onset. But patients who got more severe acute illness, who have required hospitalization, so after discharge, the first follow-up has to be arranged within 1 week time. And that's very important. Sometimes even if the patients have recovered well, if we advise them and don't ask them to follow up early, they do not follow the exercise advice, they don't follow the nutrition advice. And we've seen a number of patients whom we started on a good rehab program in the hospital, and they had started doing so well. After going back home, they did not follow up the exercise, they did not continue the tele-rehab session, and they went back to their pre-rehab level with low oxygen, breathlessness, tachypnea, and they do not realize that they've been slipping and not doing well. So we have started calling this patient within 1 week of discharge and monitor them. Patients who have persistent symptoms, they have multi-system complaints. Now, these are the ones. So group 3 and group 4 patients are the ones who really need a specialized post-COVID recovery clinic where multiple specialists are involved and a rehab program is in place. So these are the patients who really need care, because we've seen in this recovery period, they develop a lot of complications. They can develop persistent hypoxia because of pulmonary fibrosis. They can develop cardiac complications. Thromboembolism complications are also common. And post-COVID asthenia, fatigue, or loss of muscle mass and not going back to their level of activity, deconditioning, and new onset infections are very common complication that we are seeing in these patients. So what do we do in our post-COVID clinic? What assessment we do? So we analyze, or we in detail ask them about their present symptoms. What are the current medication they have been taking? Now we've seen that many times these patients have been given some blanket treatment and they do not go back and follow up in their COVID facilities. So they continue to take their steroid, they continue to take their anxiolytic, or sometimes they are not given anticoagulations and all those things. So we go back to their history and details of all the medication they have received and what current medication they are continuing. Then the vital parameters, so many patients, they have tachycardia. Tachycardia is a very common finding. We get high respiratory rate, tachypnea, and hypoxia. We also make them walk a bit and see how their tachycardia and hypoxia is worsening. And temperature, sometimes there may be some new onset infection. So general examination just to see their, the muscle functioning and muscle strength is very important, because a lot of them lose weight. And we've seen patients even with mild symptoms, they have lost a lot of weight and a lot of muscle mass. Systemic examination is very important. For common systems, they get involved. Respiratory, of course, we all know, but these patients also can develop myocarditis, pre-existing cardiac functions can worsen. Neurological complications are also very common. We've seen patients coming with stroke or Guillain-Barré syndrome. So systemic evaluation of all this cardiology, respiratory, neurological evaluations are very important. Some of patients are coming with hematological issues also. Me and Dr. Dipanjan have managed quite a few patients who are coming with thrombocytopenia, anemia, and they get anticoagulation, they do have bleeding, and they have bone marrow suppression. Or many times it may be a sign of some secondary ongoing infection. We check for their effort tolerance by making them walk or doing some objective parameters. And the nutritional status is very important. So what investigation we advise to our patient? Complete blood count, sugar levels, CRP levels to see for ongoing inflammation. So many patients have ongoing post-COVID inflammation or any new onset infection. Or if we have baseline levels, then we can compare whether all the parameters are coming down. So LDH level, D-dimer levels, renal chemistry, electrolytes, LFT, especially serum protein level. Then many patients we have recovered that you keep having this vague bone, joint pain and body aches, and they do have vitamin B12 deficiency. And we also check for vitamin D3 levels. Then radiological investigations, if the patient have had any previous pulmonary involvement, or if there is hypoxia, then we do HRCT scan chest plane. All patients do not require if they do not have hypoxia or previous respiratory involvement. And many patients who got unexplained breathlessness and tachycardia, and then we do CT pulmonary angiography. If we don't get our answers in plain CT chest, the patient with having neurological issues may require some other imaging like MRI or CT brain. Physiological assessment is very important. The patient, especially patient presenting with breathlessness or fatigue or having a previous lung involvement, we subject them to complete PFT with diffusion study, and also body box and lung volume where required. And 6-minute walk test, this test has become very famous because all the patients, while they were they have acute infection have been doing this 6-minute walk test, but post-COVID state also, this is very important for us to decide the baseline. And especially when we are going to put this patient on rehab program, then we need to have a baseline 6-minute walk test and cardiac evaluation as and when required. So if some patient with unexplained fatigue and breathlessness or persistent tachycardia, we do get their ECG and 2D echo and a cardiac evaluation done. So which are the patients in whom we do complete PFT with diffusion studies? So now it's in past 2 months, we have started doing the PFTs, and earlier there was no proper guidelines and we're really worried about, subjecting our instrument as well as our staff to infections. So we were not doing the PFT, but now we have started doing in post-COVID patients. So patients who got, and this is done 6 weeks after the first PCR positivity, not before that. Because sometimes there may be delayed viral shedding. So after 6 weeks, that's much less likely. In these patients, we do PFT. Persistent patients who have persistent pulmonary symptoms like cough and breathlessness, or patients initially have had severe pulmonary disease, clinical and radiological on radiological assessment. So those who have got lung fibrosis or bronchiectasis or ground glass opacity, and that's one of the most common presentation. So all these patients on follow-up after 6 weeks, they undergo PFT testing. Then antifibrotics also have been used almost as commonly as the steroids, and they have lung involvement, but there are no real good studies to say their effectiveness. But when you are treating your patient with antifibrotics, it is very, very important that you document with pulmonary function tests. And you've seen many of our patients have recovered without antifibrotic, and many patients have required antifibrotic for a shorter period, because one thing is now being realized that fibrosis that is happening in post-COVID patient is not behaving like the idiopathic pulmonary fibrosis, and majority of these patients are recovering clinically as well as radiologically. So they do not need long-term antifibrotic. And sometimes the radiological improvement lags behind. So in these cases, it is very important to have PFT documentation. So once the patient's PFT becomes normal and diffusion becomes normal, we stop the antifibrotics. Patients who had prolonged use of steroid, these patients also, we need to see how they are doing their diffusion test, and patients who are having persistent HSCT findings. So these are the patients whom we do complete PFT. And so far we've done more than 50 PFTs, and the commonest finding that we've found is restrictive disability. So their lung volumes go down, and diffusion defect. So their oxygen taking capacity goes down. So that's the commonest finding we've seen in our patient. But PFT should not be done in all, and there are certain contraindications. If your patient has new onset fever, then you must rule out infection. So any new onset fever or new onset LRTI, or some patients who have high risk of reinfection, these are the patients who should not be subjected to PFT. Patient is requiring too much of oxygen, he will not be able to perform PFT. So if a patient has breathlessness or oxygen requirement, then they will not be able to perform. And if it's still not 6 weeks from the first positive swab, then you have to wait for a few days and then do it. And any unstable cardiac condition, you should not be doing PFT. So just to tell you the gist of what comprehensive evaluation we do in post-COVID patient presenting. So just an example. So now there's not enough time to cover every symptomatology, but just to give an example that how comprehensively you have to evaluate the patient when your patient, post-COVID patient, is presenting with symptoms. Say a post-COVID patient present with dyspnea and fatigue, you have to consider all the aspects. So respiratory involvement, of course, that's the most commonest that we see in this patient, but many of these patients have got cardiac evaluation. They have myocarditis, or they have left ventricular failure. Thromboembolism also is a very important consideration in this patient presenting with dyspnea, and physical deconditioning, muscle wasting. So a lot of our patients who sometimes require readmission for post-COVID syndrome, they've been in the hospital for more than 3 weeks, immobility, poor nutrition. So they have a lot of physical deconditioning, muscle wasting. nutritional deficiency. Secondary infection is also pretty much common, and not all patients would present with fever, especially if they have been taking steroids. So recently we've had a patient who presented with breathlessness, hypoxia, and tachycardia, and CT scan showed new lesions. We did her bronchoscopy and BAL, and we found that she had pneumocystis carinii infection. So all these have to be considered when your patient presents with breathlessness, depression, anxiety, and worsening of pre-existing comorbidities, like my patient who had interstitial lung disease and her pre-existing condition worsened. Patient can also develop neurological condition like Guillain-Barré syndrome. So when your patient comes with breathlessness and fatigue, you have to evaluate all the aspects, and it's not uncommon that we are seeing patients having at least 3 or 4 of these conditions, which makes them breathless and hypoxic. Coming to the pulmonary rehabilitation. So various types of rehabilitation can be offered to a patient. One is inpatient, and I think that's the most crucial time to introduce pulmonary rehabilitation, because patients themselves never realize the importance of rehabilitation, and after going back home, it becomes difficult to catch them and motivate. So nowadays we have started introducing rehabilitation while the patients are in the hospital. Outpatient, it can either be done in person. Now we've also started taking patients, so they can physically come to our facility, or tele-rehabilitation, depending on what is their comfort level. Sometimes patients do not have too much of symptoms, or they don't need too much of assistance. Then we just give them a single session. This single session with our physiotherapist, head of department of cardiopulmonary rehab, also helps them a lot is to decide that how they should be planning their activity, how they should get back to the normal level of activity, what to do, how to do. Or sometimes they take isolated multiple sessions like once a week or so. These sessions are extremely important. We tell you, as clinicians, we really do not have time or understanding of all these issues of how to get a patient back to their normal level of activity. And it's good to involve your rehab specialists into this. Then we have started taking group sessions, maintaining social distancing, and that is really helping them. So we give them a lot of understanding about their disease and what intervention they can do, and also breathing exercises, relaxation, sound therapy. And at Jupiter, we have a full-time sound therapist who gives them sound therapy, and that is really helping patients with insomnia, their depression, anxiety. And we also do this in group sessions. So I'll just briefly discuss a case. This patient was a 56-year-old male doctor who developed COVID pneumonia, and he had a very severe pneumonia. He required 3 weeks of ICU stay, and he remained in the hospital for 35 days. And he required high flow nasal cannula, he required NIV. And yeah, he was, as I told you, he was in ICU for 3 weeks. Severe hypoxia, and he developed significant pulmonary fibrosis. So while he was in the hospital, we started rehabilitation. He really had a stormy course, very rapidly progressive disease, and that being a doctor, knowing everything and seeing himself going through that journey definitely made him very anxious and depressed and apprehensive. After 35 days, we could finally discharge him with home oxygen therapy of 2 liters per minute. And at the time of discharge, we did his 6-minute walk distance. It was about 180 meters. And he was given pirfenidone, anticoagulation, and tele-rehabilitation exercise prescription was given. He was introduced to rehab while he was in hospital, and then tele-rehab was continued at home. This is his X-ray just to let you know the severity of the lung fibrosis that he had. And after 1 month, he visited the OPD, and he sincerely continued the rehab session at home. And after 1 month, he was able to maintain his oxygen around 94% at room air, even on exertion. And 6-minute walk distance had almost doubled. From 180 meters, it had become 330 meters. And at this point, we had to stop pirfenidone because he did not tolerate it. But even without pirfenidone, he improved, and he could join back work 2 months post-discharge. So as you can see, the X-ray extensive involvement and gradually at the time of follow-up, so majority of these patients who are getting post-COVID fibrosis are recovering completely with or without pirfenidone. And what we have seen, the game changer is the rehabilitation. We've had different groups of patients. There are patients who do not understand or they do not take it seriously and don't do the rehabilitation. And we've seen them not getting off their oxygen for 3 months, 4 months post-discharge, while patients who are doing the rehabilitation seriously, they are getting off oxygen, they're getting back to their normalcy much, much faster. So what are the components of post-COVID rehab? It is an individualized program which is tailored to patient needs. And this is very important. Depending on the patient, his age, his baseline condition, the comorbidities, even his psychological status, you have to give them the intervention very gradually, and that assessment is very important. So just to give an example, so one of my doctor friend was admitted, and he used to do breathing exercises before. There's some breathing exercises which we had taught him before. But after recovering from COVID, he started finding it very difficult to do these exercises. So then we involved our cardiopulmonary rehab specialist, and he said that individually, first we'll have to give him breath retraining and give him some simple exercises. And once it gets better, then you can reintroduce the breathing exercises. And that's what we did. And then he started improving. So many people just think that any form of yoga, any form of breathing exercise or any other exercise is okay, but it's not so. This has to be an individualized approach, a multidisciplinary approach, and all attention to the physical and social functioning has to be. So all these components are taken into consideration while planning pulmonary rehabilitation. So we have multidisciplinary team, pulmonologists, cardiologists as and when required, rehab specialist, occupational therapist, nurse, nutritionist, psychologist. So currently we don't have this luxury of having all this, but what we do is in our post-COVID clinic, pulmonologist, rehab specialist, and psychologist. So this is what we are having. That's and we are giving, and as and when required, if patients have some other system involvement, and then the specialist opinion is taken. So in this structured rehab program, we do proper patient selection, patient assessment, and individualized program. That's what is very important. So the exercise components are extremely important. So in these patients, usually we have to give them light stretches. So initially start with breath retraining, the light stretching exercise, and a little bit of strengthening exercise. So once they become comfortable, the muscle pain reduces, the strengthening happens, and the breathing pattern changes, then the aerobic component is introduced. And then gradually different components or graded exercises are being given. That is very important in these patients who have multiple symptoms. So what intervention should be given at what time is a very important consideration in rehabilitation of these patients. There are multiple benefits of it. Helps to reduce the capacity, improves quality of life, a lot of psychosocial benefit, and also it can reduce re-hospitalization of the patient. And we have seen distinctly patients who follow the rehab and patients who do not follow the rehab, the ones who got moderate to severe disease, and we've seen that stark difference in the two groups. So how the rehab helps? So increased breathlessness leads to less activity. It leads to more physical deconditioning, further decreased exercise capacity. So patient goes into a vicious cycle. So pulmonary rehabilitation helps this vicious cycle to become a precious cycle. So reduce breathlessness, and then physical reconditioning, increase exercise capacity, ability to do day-to-day activity, and getting back their confidence level. So these are the essential components of post-COVID rehabilitation: patient education, aerobic training, muscle training, strength and endurance training, and nutrition. So we guide our patient in all these 5 components to get maximum benefit. This is our post-COVID clinic. It's a group session that we're doing. Our psychologist is talking to the patients and the relatives. This is a patient post-COVID who had a lot of insomnia, anxiety, and fear. So she's been given sound therapy. After 6 or 7 sessions, she felt much better. This is our own small study we did in 12 patients with post-COVID pulmonary fibrosis. They were recruited in this study. All these patients underwent 10 sessions of telerehabilitation, about 2 sessions a week. Even the case that I discussed of that male doctor is also included in this. So we did 6-minute walk test, functional independent measure score, and desaturation were recorded in the first and the last session. And on the subgroup analysis, what we found that there was a significant difference in the 6-minute walk test. You can see here, pre was 134 means, and post it developed, it increased to 353. So almost more than 200 meters of improvement in 6-minute walk distance after 10 sessions. Then functional independent measure score also significantly improved, 51.67. And desaturation also significantly improved by up to 7.17%. So all were statistically significant. So many people have a lot of myths about post-COVID rehabilitation, and I think we should help our patient. And sometimes we ourselves also have these myths. Many of my doctor friends had come to me and they were not really convinced about post-COVID rehab. So we think that post-COVID syndrome is symptoms are just will recur with time. No, we have seen that if you don't pay attention to it, you may continue to have symptoms even 3 to 6 months post-COVID. It is like any other physiotherapy, walking or yoga, and it is not. It's a very structured, multidisciplinary approach. Many people, they are so, exhausted with their money, so they don't want to spend more money, although it's just about 500 to 600 rupees a session, and they find it too expensive. But I think many of our patients who've been able to get back to work have realized the value that this is probably the most cost-effective intervention that one can have. And sometimes they don't want to do it because they don't feel better. So they feel that they will start exercising once they feel better, and that will make them more deconditioned. And quite a few patients still have fear of reinfection. I think we should help our patient to get out of all these myths and guide them properly. So my last slide. Post-COVID syndrome is emerging as a spectrum of condition impacting recovery from COVID infection. Mild and low risk subjects can be managed with symptomatic treatment. They do need a lot of reassurance, but your patients with moderate to severe post-COVID syndrome need multidisciplinary team involvement and a structured rehabilitation program. So do guide your patient and can refer them to the right facility. This is our post-COVID clinic. We do clinical assessment, functional assessment, specialist referral as and when required, and counseling sessions online as well as offline. In the counseling session, we give them, we tell them about the post-COVID syndrome, guide them about diet, nutrition, psychological counseling, breathing exercises, meditation, sound therapy, all that is taught to them in group session. So we are running this clinic Tuesdays and Fridays between 3 p.m. to 5 p.m. and group sessions are done on Fridays, 5 to 6 p.m. And that's the contact number. So if any of you are interested, you can take the number and you can share with your friends or your patients. So thank you for your patient hearing. I'll be happy to take the questions.
Thank you, Dr. Alpa. This was a very informative lecture on post-COVID journey. As you rightly pointed out, healthy lung, that is the main aim of this. So yeah, welcome. Any questions, please?
Before the question answer session, let me interrupt you. I'm Dr. Santosh Kadam, President IMA Thane, and we are privileged to have with us our Supreme Leader, State President Dr. Ramkrishna Londe with us. Can you take Dr. Ramkrishna Londe on the screen, please?
He's there.
Please take her. Yes. Welcome, Ramkrishna Londe, sir. Ramkrishna Lode sir has become president of IMA.
Thank you, sir.
IMA Maharashtra State yesterday. He took over from Dr. Avinash Bondwe. A small installation function was held at Usmanabad. He is a very senior leader in IMA Maharashtra State as well as national. He is devoted for the IMA work for last 40 years. I have seen him attending all the council executive meeting for last 30-40 years without fail. लोंढे सर आभारी आहोत. आपली सेंट्रल वर्किंग कमिटीची मीटिंग चालू होती तरी सुद्धा आपण 1 मिनिटासाठी इकडे आलात. थोडंसं
थँक्यू सर. बेस्ट विशेष.
हा, मी आता तुम्हाला ऑनलाईनच बुके देऊन आपला सत्कार करतो आहे.
थँक्यू सर. I got it.
हा, ओके. सो आम्ही IMA ठाण्याच्या वतीने
थँक्यू.
आपलं स्वागत करतो आणि आपण 1 मिनिटासाठी आम्हाला ऍड्रेस करावा अशी विनंती करतो. लोंढे सर, IMA ठाणे आणि बरेचसे मेंबर्स IMA ठाणे.
बोला सर.
आपण थोडासा ऍड्रेस करावा 1 मिनिटासाठी. कालच आपण टेक ओव्हर केलेला आहे डॉक्टर अविनाश भोंडवेकडून राज्याचे अध्यक्ष म्हणून.
धन्यवाद. तुमच्या कार्यक्रमाला माझ्यातर्फे पहिल्यांदा हार्दिक शुभेच्छा.
हो.
ऑडिबल आहे? आहे का इथे?
येस.
ओके. ऑडिबल, व्हिजिबल?
हो, येस दोन्ही पण.
ओके. थँक्यू सर. जगदंबेच्या कृपेने मराठवाड्याला चान्स मिळालेला आहे.
हो.
तुम्हाला ती कल्पनाच आहे आणि तुमच्या कार्यक्रमाला माझ्यातर्फे हार्दिक शुभेच्छा.
धन्यवाद.
आणि या कोरोनाच्या ह्याच्यामध्ये सुद्धा तुम्ही खूप चांगलं काम करताय. त्या निमित्तानं तुमच्या ब्रँचला सुद्धा हार्दिक शुभेच्छा. आणि स्टेट लेवल कडनं जर तुम्हाला काही कामाची म्हणजे काय मदत भासली तर आय विल बी देअर टू हेल्प यू. आय विल बी हॅपी टू हेल्प यू.
येस सर.
ओके.
थँक्यू सर. थँक्यू फॉर कमिंग.
ओके सर.
अजून एकदा मी पूर्ण
ऑल द बेस्ट.
आपला आभारी आहे. आपण वेळात वेळ काढून एकदा आलात. धन्यवाद. Rahul, you can go for question and answer.
Yeah, Dr. Alpa.
Yes.
Yeah, any question answers? Aditya.
So somebody has asked whether doctors who have got says whether vaccination is required or no. So they are definitely not priority, but there are a lot of things which are not known, that how long the protection would last, how long the antibodies would last. So I had talked to one of my batchmates who is working in development of vaccines. So he said that probably they are not priority to give vaccination because they already have antibodies.
Okay, there's one more question, Alpa ma'am. Cardiac evaluation in post-COVID discharge patients. When and which patient to be advised?
So post-COVID patients, patients who have got persistent tachycardia, patients who have got persistent breathlessness, fatigue, which is not explained with your respiratory evaluation, and patients who become hypotensive. So these are the patients whom we report for cardiac evaluation, because post-COVID myocarditis is also very common presentation we are getting, and these patients, apart from their ECG, and 2D echo evaluation, they also are subjected to cardiac MRIs. So your patients who got pre-existing cardiac condition, who got pre-existing diabetes, or they have pre-existing other comorbidities, and breathlessness and tachycardia, which is out of proportional to the respiratory involvement, these are the patients who should get subjected to cardiac evaluation.
Any specific yogasanas you recommend?
Okay, so in initial post recovery phase, light stretching exercises are helping. So it depends on how your patient, whether patient is young and flexible, then Yog Mudra is very helpful. Pavan Muktasana is very helpful. Even Tadasana is helpful, and just about any asana would be helpful, but more than yogasana, I think pranayam would be much more beneficial. So sectional breathing exercises and pranayam, and we teach different type of breathing exercises called holistic breathing exercises. So these are very helpful.
Can spirometry will be helpful rather than the yogasana, because yogasana depend on inhalation and exhalation. So can we advise the spirometry for the old age people?
I think spirometry has been overhyped. So many people, they just take this spirometry and keep on blowing. The technique is not. I think random spirometry is not really helpful. So instead of that, you should be giving them proper deep breathing exercise and breath retraining. And after having trained them, they can do spirometry. But then that gives them some objective parameter. If it start with 500 and 750 and 1000, it improves. So that gives them an incentive to do it. That's why it is called incentive spirometry. But it has to be there given with proper technique. And that by itself is not enough. So sometimes they have this incentive spirometry. So very doctors and patients, they have false sense of assurance that they are doing spirometry means they are doing fine.
Yeah, that's why I ask. Okay. Any question, I think?
Okay, Rahul, let me once again say thanks to Dr. Dinkar Masde and welcome him on the panel. He is the observer from Maharashtra Medical Council on the screen. And there are few dignitaries in the panel. Dr. Sumit Upasne, who is president of IMA Dombivali. So I welcome him on the panel. Dr. Dinkar Masde, and in the audience there is Dr. Senior Hasse also, who is head of the department of the KM Nephrology Department. So with this, I will hand over to Dr. Vedas Nimkar. We are to the end of the program now. I welcome Dr. Vedas Nimkar to say vote of thanks, if there are no questions.
Hello to everyone. This was the first CME of Thane branch of IMA, which was MMC approved. And I would like to at the onset thank our president, our dynamic president, Dr. Santosh Kadam sir, who was inspiration behind this. And he's been our guiding light. I would like to thank all the panelists, Dr. Haldar, Dr. Hasse, Dr. Dalal, for their wonderful and exhaustive case studies and talks. I would like to thank the MMC team who at a short notice has given us accreditation. Especially thanks go out to MMC President Dr. Utture sir and the Office Superintendent Mr. Sawant and Dr. Dinkar sir, who's our observer today. There is a lot of effort which has gone into it, and the credit for it is due to our CME team, that is Dr. Rahul Bapat, Dr. Kamlesh Thakkar, Dr. Boricha, and the entire executive committee team of IMA Thane for making this success. I would like to thank everyone from the audience, the distinguished doctors, not just from Thane branch, but also from all over Maharashtra, who have spared time and attended and made this program a huge success. And thanks go out to our digital partner DigiShield. CEO Mr. Dipan is here, and the technical team, Mr. Aditya, Mr. Siddharth, they have done a wonderful job in helping us with the providing the backbone for this webinar. And I would like to thank Team INTAS, Dr. Akhil and Mr. Yadav for their unrestricted educational grant and academic support. So with that, we conclude this program today. Before we say goodbye, I would like to request all the members of IMA Thane to attend the AGM that we have scheduled today on Zoom platform at 3 p.m. So I request them all to attend in large numbers. Over to you, Dr. Santosh sir.
Okay, okay then. Thanks everybody. We will conclude here, and thanks for the meeting.
Yeah, thank you, sir.